Hello, hi guys. I hope I'm audible and visible to you. Can I just have a thumbs up in the comment box if I'm audible and visible to you? Okay, good evening. Uh, right. So guys, thank you so much for joining in. And yeah, earlier there was a bit of a glitch. Yeah, okay. So I think whatever the things were there, they have kind of got resolved. And today we are here to discuss about the one-shot revision in surgery NEET PG 2024 Part 1. I'll be doing this particular session in the two parts. This is the first part. The second part will be done probably in a couple of days. I will be uploading it on this particular same YouTube channel. It will be conducted live on this particular same YouTube channel. Okay. So I think I do not expect a lot of people over here because probably this is my first stream on this particular channel. But yeah, I mean, that's kind of okay, right? So I think we should start. Yep. Or we should wait for a couple of minutes. Now, there has been a couple of comments by the people. Right. So I'll try my level best to kind of provide the maximum value through this particular session. And so can you complete our library closes at 11, next session thoda jaldi. Okay, I will try to kind of figure that particular thing out. Yeah, I'll try to do that. Okay, so without wasting any further time, let's kind of start and let's start with this particular kind of a thing. Yes, I know. Yep. Hi, Karan. Right. So today what we are going to cover over here is we are basically going to cover what you call as okay, so we are going to cover the general surgery, we are going to cover the vascular surgery, we are going to cover the thyroid, we are going to cover the breast. So there are too many things to cover over here today. So yeah, let's start without wasting any further time. Okay, so the first topic which we all kind of talk about is the wound healing. Now, what you need to understand about the wound healing basically comprises of the three phases. Okay, so there are the three phases of the wound healing. We have the phase of inflammation, then we have a proliferation, and then we have a remodeling. Now, what happens in the inflammation? In the inflammation, there is also something which is called the hemostasis. Okay, so the hemostasis first occurs, then there is a phase of an inflammation where all the the neutrophils and the macrophages, neutrophils basically they come in. Those are the cells basically predominantly responsible for this inflammatory phase. Then the proliferative phase, what happens? There is a laying down of the extracellular matrix. So predominantly the collagen type 3 is the one which is basically laid down over here. And then what you need to understand, in the phase of the remodeling, essentially what happens is that the collagen type 3 is basically converted into or it is replaced by the collagen type 1. And the important thing and a very basic thing, I'm pretty sure that you guys must be knowing about this, is ultimately what we achieve is that the collagen type 1 is to type 3. The ratio which we achieve at the end is 4:1. Okay, so this is what you need to understand. In the phase of the remodeling, another thing which basically happens is the wound contraction. Okay, so the wound contraction, that is also something which is basically happening in this what you call as a remodeling phase. Okay, then ultimately what happens is that over a period of time the strength of the wound basically kind of increases and we attain 80% of the strength by around third month. Okay, so this is what is basically happening in the basics of the wound healing. Okay, then let's talk about the factors which affect the wound healing. So can you please tell me what are the factors? So broadly what you can say is that there are the local factors and there are the systemic factors. What are the local factors? Whether that particular tissue is receiving adequate amount of the blood supply, or whether the oxygen or the hemodynamic status of that particular patient is good or not. So for example, if at all the patient is in the state of shock, what is going to happen? The healing is going to be kind of poor. So those are the local factors which we are going to talk about. Which we are not going to talk about in elaborate manner, but those are the local factors. Then we have a systemic factors. Now, what are these particular systemic factors? This basically includes, let's say, the nutrition of the patient, or let's say there's some patient who is having some kind of a medical disease like diabetes mellitus, or let's say the patient is basically having uremia. Okay, so uremic encephalopathy or something like that. Uremia, basically like hepatic failure, uremia, all those particular things, they basically hamper whatever the wound healing. Now, one thing which they had asked you, medications. Okay, so which medication is going to delay the wound healing? It is the steroids. Okay, so do remember this: diabetes mellitus, then we have a uremia, and then Steroids is a medication which is going to delay the wound healing. That is something which you need to understand over here. Okay, I hope you have understood this particular point, right? Okay, now before I kind of proceed any further, I'm just trying to tell you that obviously I'm going to go in a very fast manner because this is basically a rapid revision. We have a lot of things to kind of cover in this particular 3 hours. Okay, so up to what time the session? At least by 12:30 probably. Okay, so today the session probably will be at least till 12:30. Okay, so that's what it's going to be. Okay, now let's talk about the classification of the wound. The classification of wound, what you need to understand is that we have a clean, contaminated, and dirty. What do you understand by the clean wound? Clean wound is basically it's again a post-operative wound. Okay, so what is it? It is a post-operative wound. Now here what you're doing is that you are not entering into any of the cavity. So here what you're doing is you're not entering in whatever the thoracic and then what you call as the abdominal or genitourinaries, any of this particular cavity you are not entering. That is what is your clean wound. Okay, so you can keep a drain, you cannot keep a drain, it's all up to you, and it is a post-operative wound. So after the surgery is done, you basically take the sutures and you basically close the skin incision. So that is what you basically do in the clean wound. I hope you have understood this point. Then what about the clean contaminated wound? This is again a post-operative wound, but here you enter. Okay, so you enter into these particular cavities. So you enter into the thoracic cavity, you enter into the abdominal cavity, you enter into the genitourinary cavity. So here you're actually entering into these particular things. Okay, what about the contaminated wound? A contaminated wound basically says that let's assume that we are performing a laparoscopic cholecystectomy, and due to some damn reason, if at all the bile basically spreads inside the abdomen. So if at all there is a breach in the normal sterility during the procedure, then you basically label it as a contaminated wound. So I hope you understood this point. Whatever the normal procedure is going on, apart from that, if at all there is a breach in the normal, like if at all there is a breach in the sterility during that particular procedure, then you basically call it a contaminated. One of the best examples is when you're taking out the gallbladder, let's say few of the gallstones, they get scattered into the abdominal cavity, or the bile gets scattered into the abdominal cavity. That is what is a contaminated wound. Another important wound is a freshly lacerated wound. Okay, so what do you understand by the freshly lacerated wound? So can you guys tell me what is the what you call as what is the golden period for any particular lacerated wound? Okay, so what is the golden period for a lacerated wound? So please try to understand over here. That is the golden period for the lacerated wound is what? For the lacerated wound is 6 hours. Okay, so 6 hours. Within the 6 hours, you can actually kind of suture. You can kind of clean that particular wound and you can take sutures on that particular wound. So that is what you need to understand over here. Okay, so a fresh lacerated wound, that is what is like considered to be a contaminated wound. Then what do we have? We have a old devitalized wound. Old devitalized wound, that is what is a dirty wound. Okay, so what do you understand by old? More than 6 hours. If at all the wound has caused, like if at all the wound has kind of gone beyond the 6 hours, that is what is a old devitalized wound, and that is what is referred to as your dirty wound. I hope you have understood this particular point, guys. Okay, then let's assume that there is some kind of a visceral perforation, that is also included in the dirty wound category. Okay, I hope you have understood this particular point. Now, why do we want to know about all these things? Because we want to understand the risk of the surgical site infection. So surgical site infection obviously is more in the clean, contaminated, and dirty. Okay, so like as you kind of go towards the dirty, obviously the surgical site infection, the risk basically is going to kind of increase. Okay, understood? Now, let's talk about how do you prevent this particular surgical site infection. How you can kind of prevent the surgical site infection pre-op bathing. Like obviously you can ask the patients that, you know what, one day before the or let's say in the morning of the surgery, the patients basically take bath. That's not that important, that's fine. Hair removal. So can you please tell me how do you remove the hairs of a patient? Like assume that somebody wants to operate on my hand. Okay, so there are a few like hairs over here. How do we kind of remove it? Do you kind of shave it or do you do something else? So please understand, you never ever shave that particular part. So what you basically do is you do trimming. Okay, so what you basically do is you do trimming. And where do you want to do this particular trimming? On table. Okay, so on table trimming, that is something which is important. It is not 1 day prior, and it is not shaving. It is on table trimming, clipping. That's what clipping basically. Okay, then a very important thing is a pre-op antibiotic. Okay, so we give a prophylactic antibiotic before the surgery is basically done. So the most important question which they ask you is that when do you give this particular prophylactic antibiotic? So the prophylactic antibiotic is basically given 1 hour before the surgery. Okay, so please try to understand 1 hour before the surgery, or if at all that is not given in the option, then at the time of induction of anesthesia. So when do you kind of give that? 1 hour before the surgery or before the induction of the anesthesia. Okay, then what you need to understand, painting. So yeah, that's fine. You can take a like povidone iodine or chlorhexidine, and then you kind of do the painting of the patient. Okay, so what is preferred? Povidone iodine is preferred or chlorhexidine is preferred. This was asked a couple of years back. Okay, so please try to understand, as per the efficacy, both are more or less the kind of similar, but chlorhexidine is preferred over povidone iodine. Okay, so chlorhexidine is something which is kind of preferred over the povidone iodine as per the WHO. So WHO basically says that the chlorhexidine is something which is going to be preferred. Okay, so I hope you are able to understand this point. And then we have to kind of prevent the hypothermia, because hypothermia increases the risk of infection and bleeding. Okay, so hypothermia increases this particular risk, so you have to kind of ensure that you are making sure that the the hypothermia is kind of reduced during this particular stuff. Okay. So wash of the organs, antibiotic wash of the organs, it depends on the procedure what you're basically doing. Okay, so it is not mandatory. Every time you are kind of doing an abdominal surgery, you don't give that particular antibiotic wash. And again, frankly, the antibiotic wash basically acts more like a placebo rather than kind of actually helping up, but that's fine. You can give it at the end of the procedure. So some surgeons basically give it a betadine wash. Okay, so what they do is they take a lot of kind of saline and they add some very small amount of the betadine, and then they kind of wash the abdominal cavity based on that. If at all there was a, let's say, purulent peritonitis, or let's say there is a feculent peritonitis or something like that. Okay, in that you can also add gentamicin a bit. Okay, but it's not like a pure antibiotic is kind of put. It is a very diluted form of the antibiotic, or the betadine is something which is going to be put, but that's not kind of a very objective thing. It is going to be varying from surgeon to surgeon. Okay, then what about the wound closure? After the surgery is done, there are 3 types of the wound closure which we can do. There is a primary closure, there is a secondary closure, and there is a tertiary closure. What do you understand by the primary closure? Primary closure means that after the surgery, you have taken the sutures. Okay, so you have taken the sutures and you have closed that particular wound. That is what is called as a primary closure. Secondary closure means that after the surgery, you did not take the sutures. You just kept that particular wound open itself, and you allowed the wound to kind of heal with the granulation tissue. Okay, then what about the tertiary? Tertiary is also referred to as a delayed primary. Okay, so what is this particular tertiary? Tertiary is also referred to as your delayed primary closure. So this is basically to prevent the infection complications. So here what you basically do is that you keep the wounds open, and then you kind of do the dressing, you kind of like give the antibiotics to the patients and everything, and after, let's say, 24 to 48 hours or something like that, now you close that particular wound. So this is what is referred to as your delayed primary closure. This is also referred to as your tertiary closure or a delayed primary closure. Okay, so I hope you have understood this particular point. Okay, then what is this particular image? This is an image of a degloving injury. Now what happens in this particular degloving injury, that there is a frictional kind of a force, and the skin basically gets separated from the underlying tendons and the muscles and everything. So this is what is referred to as your degloving injury. So when does this particular thing happens? So what you need to understand, if at all there is a frictional force, then this particular kind of an injury can happen, and this is an image which is basically trying to show that this is what is a degloving injury. Now the problem with this is the skin. Okay, this particular skin is going to be non-viable. Okay, so many times you have to kind of excise that particular skin, and the surgeon basically has to think about the coverage, because you cannot just keep it open. Then after the wound is kind of fresh and everything, then you can kind of go ahead and put a grafting over here. If at all it is not infected, you can go ahead with immediate grafting, if not delayed grafting. So that's all different story. At your level, at least what you should understand is what is this? This is what is a degloving injury. Okay, yep, I hope you have understood, right? Yep. Now a very important topic is a compartment syndrome. Now what happens in this particular compartment syndrome is that this happens after the crash injury. What do you understand by the crash injury? Let's assume that the patient met with an accident, and over that particular poor leg or something like that, very heavy vehicle has kind of passed away. This is one of the examples of a crash injury. Now what happens is that whenever the crash injury happens, the muscles, they basically are injured, and they basically become edematous, and they start to swell up and everything. Now what you need to understand is that surrounding the muscle there is a facial compartment, and this particular facial compartment, or this particular fascia, this is not going to kind of give away. Okay, this is not a very easily kind of giving away. Okay, so because of this, what is going to happen, the pressure inside that particular compartment is going to rise up. And how much this particular pressure is going to rise up? Once this particular pressure rises up about 30 millimeters of mercury. Okay, if at all the pressure goes beyond the 30 millimeters of mercury, then we say that, you know what, the patient is basically suffering from a compartment syndrome. Why? Because after this 30 millimeters of mercury, what is affected is the microvasculature. So there is a defect of the microvasculature. Microvasculature means the small vessels which are basically supplying the muscles, they are basically affected, and those particular microvasculature, the blood basically goes very less in that, and because of this the muscles become ischemic, and because of that the patients basically develop pain and all those particular stuff is going to happen. Okay, I hope you're able to understand this particular point. Now, when you are dealing with the patients with the compartment syndrome, what you need to understand is that the distal pulsations are going to be present in the starting phase of the compartment syndrome. Why so? Because the distal pulsations are because of the bigger vessels, and the bigger vessels are not going to get compressed with 30 millimeters of mercury. Only when that particular pressure is going to rise much higher, at that point of time, what you need to understand is that the distal pulsations is going to get kind of reduced. Okay, so here the first sign. Okay, so what is the first sign of this particular stuff is pain on the passive dorsiflexion. So usually we are dealing with the legs, and whenever you kind of passively dorsiflex the toe, at that point of time there is a pain in the calf muscle. So that is what you need to understand. What about the management? So here the management is that you have to do a fasciotomy. So what you have to do is you have to are you able to look at this particular white colored fascia? So you have to kind of cut the skin, circumcision, everything. You also have to kind of cut this particular fascia. So what is going to happen? The muscles are going to get some space, and the pressure inside that particular facial compartment is basically going to go down. Okay, so I hope you are able to understand this particular point. All these things is basically about the compartment syndrome. Okay, right? Okay, now I'll just kind of address a couple of questions. Tertiary done in what type of wound, sir? Okay, I'll address that. So deep fascia, blah blah blah, is not always. Okay, deep fascia is cut. Okay, so that's fine. That's what I told you. Deep fascia is always cut whenever you are trying to kind of manage the patients of a compartment syndrome. Tertiary done in the leaking injury. Yes, absolutely right. Okay, so that by what you need to understand is so if you kind of read your Levin Bailey, in that it has been written, whenever you are having a typhoid perforation, always the dictum is that you have to kind of go ahead and perform a delayed primary closure. So what you basically do is you kind of close the sheath, but you don't close the subcutaneous tissue and the skin and everything. So the dictum is that whenever there is a very bad peritonitis, you kind of close the sheath. Obviously, you cannot kind of open the abdomen and everything. You close the sheath, but the subcutaneous tissue and the skin is kind of kept open. You kind of do a dressing, and you start the patient on antibiotic, and after let's say 24 to 48 hours, then you kind of do this particular delayed primary closure. Okay, I hope you have understood this point. Now, next topic is bed sore. Now, what is this particular bed sore? What you need to understand about this particular bed sore is that here what is happening. Okay, what is the cause of this? Can you please help me with this? What is the cause of this? The cause of this is prolonged immobilization. Okay, so what is this? It is immobilization. So due to any damn reason, if at all the patient is basically immobilized, okay, so it means that let's assume that there is a patient who is having a pelvic fracture, or let's say there is a patient who has become paraplegic or something like that. That is what is going to be the basic cause of this. So over a period of time, because the patient is already able to kind of move on itself, over a period of time the pressure is going to build up in the soft tissue, and because of this, what is going to happen? Again, the pressure is going to go beyond this 30 millimeters of mercury, and because of this, what is going to happen? The blood supply to the soft tissue and the skin is going to kind of get reduced, and because of this, what is going to happen? The patients are basically going to and develop this particular bed sore. Okay, I hope you got the drill. Because of the increased pressure in the subcutaneous tissue, the blood supply to the skin is kind of hampered, ultimately happening this particular bed sore. Now, what you need to understand, there is classification is what I'm trying to talk to you about, the stages of the bed sore. Now, quickly, can you please answer it in the comment box? If at all I say that there is a patient who is having a superficial loss of the epidermis with no loss of dermis. Okay, so I repeat, there is a patient who is having a superficial loss of the epidermis with no loss of dermis. What stage of the bed sore is it? Is it like the 1, 2, 3, 4? Okay, I have given you a very simple question. Please put your answers in the kind of chat box. I'll kind of go ahead. So many of you kind of will end up marking it as 1. Okay, so what you need to understand, the answer is not 1. Okay, what is the answer? Answer is 2. Okay, so in the 1, what is there? There is no breach in epidermis. All you basically have in the stage 1 bed sore is a non-blanching blanchable erythema. Okay, so what you need to understand, all you basically have in the stage 1 is a non-blanchable erythema. That is what you need to understand. In the stage 2, there is a superficial loss of just the epidermis. In the stage 3, there is involvement of epidermis plus the dermis. And in the stage 4, there is involvement of what you call as a subcutaneous tissue and whatever the muscle and the bones and everything. Okay, I hope you got the drill. The only reason why I was trying to emphasize over here is the stage 1 bed sore. In the stage 1 bed sore, there is a no breach in the epidermis. All you basically have is a non-blanchable erythema. That is all you basically have in the stage 1 bed sore. Okay, I hope you have understood. Now, what is the most common site of a bed sore? Can you please help me with this? Now, please don't mark it as sacrum. The most common site of the bed sore is ischium. Okay, ischium is the most common site of the bed sore. This is followed by what you call as a greater trochanter, and this is what is basically followed by the sacrum. Are you understand my point? So what is the most common site of the bed sore? It is the ischium. Okay, it is not the greater trochanter, but it's not the sacrum. Most common site of the bed sore is your ischium. Okay, I hope you have understood this point. Okay, now what is the management? Obviously, whenever there is a bed sore, you're going to go ahead and debride and all those particular stuff. And after you have done the dressing and everything, after the slough has kind of gone, after the dead necrotic tissue have kind of gone, after that point of time, what you are going to do is you're going to put the patients on something which is called as a VAC dressing. Now, what is this particular VAC dressing? In the VAC dressing, this is what is a VAC dressing. Okay, here what you basically do is you basically create a negative pressure. Okay, so you create a negative pressure of minus 125 millimeters of mercury. So how much is the pressure which is created in this? It is a minus 125 millimeters of mercury. So this is the amount of pressure which you basically create in the VAC dressing. How do you kind of prevent it? So you basically have to kind of like change the position of the patients very frequently. If at all the patient is paraplegic, then you have to kind of change the position of the patients every 2 hours. And if at all the patient is basically wheelchair bound, then every 10 minutes the patient has to kind of lift themselves up for around 10 seconds. So that is what you need to understand over here. This is how you're going to prevent it. Apart from that, you can also kind of use the air beds and water beds and everything in order to kind of prevent it. Now, pretty simple. This is an image, what you're basically seeing over here. This is an image of a keloid. Okay, so this is what is an image of a keloid. Why it is a keloid? Because here the abnormality of that particular scar is basically going beyond the boundaries of that particular scar. And what is this? This is what is your hypertrophic scar. Okay, so I'll just take myself away for a minute. So what you need to understand over here is that this is what is a hypertrophic scar. Now, hypertrophic scar, what you need to understand, the abnormalation is basically limited to that particular boundary of that particular scar itself. Okay, now this is what is the basic difference between the hypertrophic scar and the keloid. As I told you, that hypertrophic scar basically lies within the boundary of that. That's all fine. Extend beyond the kind of boundary. The answer is no to that. That's fine. It usually happens within 4 weeks. Familial association is kind of not present over here. Gets better with time. This is important. Okay, so if at all you just keep a hypertrophic scar, it's going to get kind of better with time. And the hypertrophic scar, you have predominantly collagen type 3, which is basically well organized. On the other hand, in the keloid, what you need to understand, it can happen in number of years after the surgery. That's fine. The most common site, as somebody has kind of rightly said, is that it's basically on the sternum. Now what they basically describe is that if you join these particular 2 points, the two whatever the kind of shoulders with the zippy sternum, in between this particular point, if at all there is a scar, there is a high likelihood that this particular might lead to a formation of a keloid. Okay, now extends beyond the boundary. The answer is yes, absolutely yes. Familial association, yes, there is an autosomal dominant kind of family association. Get better with time? No, not really. Here there is a presence of both the type 1 and the type 3 kind of collagen, but this is basically present in the wavered format. Now what about the treatment? Now treatment is very complex. Nobody is going to ask you the very specific points about the treatment of the hypertrophic scar and the keloid, but what you need to understand is the first treatment. How do you basically start is intralesional steroids. Which steroids do you give? Triamcinolone. Okay, so which steroid do you give? Triamcinolone. That is what is a steroid which you basically give. Then after that you can go ahead and do an excision and whatever the resuturing and everything, but the chances of recurrence are very high. So that is why there are various things in order to prevent the recurrence, like silicone dressing is there, compression dressing is there, there is something which is called as a pulsed dye laser, PDL. So these all are the treatments for your hypertrophic scar and the keloid. All you need to understand, the preliminary is basically your intralesional steroid injection. Okay, so that's what you need to understand. Now before I proceed further, I am pretty sure that most of you, okay, so anyways, I'll just quickly cover it. If at all you wish to connect with me and if you wish to kind of ask me any doubts or anything like that, you can just scan this particular QR code. You will have a number where you can reach out to me. This is the WhatsApp number in which I connect with the students. This is basically the YouTube channel. Basically, this is, please consider subscribing it if you have not done that. If you wish to connect with me on Instagram, this is a QR code. You can just scan it. You can connect with me over there. At this point of time, it's not that active, but like as I have just started on this particular YouTube channel, I'm going to start on my Instagram pretty fast. Okay, so that's all. Without wasting any further time, let's move on. Okay. So the next topic which we are going to talk about is the shock. Now, what about this particular shock? What you need to understand about this particular shock is that okay, so I'll not be able to cover all the types of the shock. What you're basically seeing on your screens is this is a classification of the hemorrhagic shock. Okay, so first and very basic question which you need to understand is that you have a class 1, class 2, class 3, and the class 4 hemorrhagic shock. What about the class 1 hemorrhagic shock? In the class 1 hemorrhagic shock, what you need to understand is that the blood loss is basically less than 15%. In the class 2 hemorrhagic shock, the blood loss is basically between 15 to 30%. In the class 3 hemorrhagic shock, the blood loss is basically between 30 to 40%, and the class 4 hemorrhagic shock, it is more than 40%. It's a very basic question. If you can't make this particular question wrong, it's not a very good thing. Okay, so class 1 less than 15, 15 to 30, 30 to 40, more than 40. If you convert it into the ml, it is less than 750, 1.5 liters, like 750 ml to 1.5 liters, 1.5 to 2 liters, more than 2 liters. Okay, that's a very basic thing. Now, what you need to understand is the class 1 hemorrhagic shock. This you can also refer to as a compensated hemorrhagic shock. So even though there is a blood loss which is happening, but if you take about any of these particular parameters, all these particular parameters are absolutely normal. Okay, so let's assume childbirth. Okay, in the childbirth, during that childbirth, the mother basically loses amount of blood, 100, 200, 300 ml, but the child is like, the mother is absolutely fine, right? Hemodynamically, the mother is absolutely kind of fine. Okay, right? Now, what about the class 2 hemorrhagic shock? Now, this is something which they ask you in the clinical scenarios. Okay, now what you need to understand, in the class 2 hemorrhagic shock, the systolic blood pressure is absolutely normal. But if you look at all the other things, okay, if you look at the other things, for example, the heart rate, it's slightly elevated. If you look at what you call as the respiratory rate, it is slightly elevated, urine output is slightly reduced, extremities are slightly pale, the patient is slightly anxious. So this is what they're going to give you in the clinical scenario. They're going to give you that after the road traffic accident, the patient has come to you, the heart rate of the patient is 104, respiratory rate of the patient is 22, urine output is 26 ml per hour, extremities are whatever, they'll not give you about extremities and everything. They'll like emphasize on this that the systolic blood pressure of the patient is normal. What class of this particular shock is there? It is a class 2 hemorrhagic shock. It is not a class 1 hemorrhagic shock. I hope you've understood this particular point. These are the two very basic questions on the this particular classification of the hemorrhagic shock. I hope you've understood this particular point. Okay, right. Now, is the voice really low, guys? Is the voice really low? Okay, I understand. I faced this particular problem last time also. I don't know where there's some technical issue or something like that, but yeah, I hope the voice is kind of okay now. Okay, if at all there is a significant problem with the voice, please kind of comment, but I hope it's kind of okay now. Okay, now moving ahead, then we have something which is called the shock index and modified shock index. Now, just remember these particular formulas. What is the shock index? Shock index is basically heart rate upon the systolic blood pressure. Modified shock index is basically heart rate upon the mean arterial pressure. Okay, so that's what you need to understand over here. Okay, right? Okay, yeah, right. Yeah. Then we have a blood transfusion. So again, blood transfusion is a very small topic, but a very important topic. So in the blood transfusion, what you need to understand, the two things which you need to understand is the full forms of these particular things, CPDA and SAGM. So what does this particular CPDA stands for? Citrate, phosphate, dextrose, and adenine. Okay, so what is the CPDA? Citrate, phosphate, dextrose, adenine. SAGM. Now here, please try to understand, S is not basically, this is a boo-boo. Okay, this is not sucrose. Okay, it is not sucrose. I'm really sorry. On the slide, it is kind of written wrong. So this is what is saline, guys. Okay, what is this? This is what is the saline, then adenine glucose mannitol. Okay, so please understand this. Okay, on the slide by mistake, I think there was sucrose. That's fine, but I hope you've understood. SAGM is basically saline, adenine glucose, and the mannitol. Okay, so please understand this. Okay, right. Now, what are these SAGM and what is CPDA? These are the basically anticoagulants. So what you need to understand is that once anybody donates the blood, either you can use that particular blood directly, or what you can do is you can break that particular blood into the different kind of components based on the centrifugation. With the help of the centrifugation, we can break it down into the different components like red cell concentrate, that is PCV, packed cell volume red cell concentrate, or FFP, that is fresh frozen plasma, and the platelet. So you can basically break them into these particular stuff, right? Now, what about the red cell concentrate? Red cell concentrate is basically stored at 2 to 6 degrees Celsius. Please understand this point. You cannot like if at all you have a whole blood, or let's say red cell concentrate, it should not kind of go below 0 degrees Celsius. Otherwise, you will have to discard it. Then it's going to become non-usable. Okay, I hope you've understood this particular point, guys. Okay, now this particular red cell concentrate or the whole blood, it can be stored for around 35 days. Okay, how? Based on because we are using CPTA, citrate, phosphate, dextrose, and adenine. Okay, that is an anticoagulant which we're using. With the help of that, we can store this particular blood for around 35 days. Okay, right? Right, that's what you need to understand about the red cell concentrate or the whole blood. Then what about the plasma components? So what are the plasma components? We have the fresh frozen plasma and the cryoprecipitate. So they are basically stored at -30 to -40 degrees Celsius. -30 to -40 degrees Celsius, they can be stored for 2 years. So FFP and the cryoprecipitate, those particular things can be stored for 2 years. Then what we have is the platelets. Platelets are basically stored at the room temperature. They can be stored only for 5 to 7 days. They are basically stored in the what you call as an agitator. Okay, on an agitator you basically store these particular platelets for around 5 to 7 days. Their shelf life is only for around 5 to 7 days. Okay, so these are the basic things about the blood transfusion which you need to understand. Okay, so that by is asking, sir, also tell some points about the TACO and the TRALI. So what is a TACO? TACO basically is transfusion related cardiac overload. So what you need to understand over here is that, okay, so you are, let's assume that I am a heart patient and I am in the state of a compensated heart failure. It means my heart is somehow managing to kind of maintain the blood, somehow managing to kind of do its own function. Now, one fine morning you come and you basically transfuse 3 units of blood to me. What's going to happen? There's going to be the volume overload, and my heart, which was just somehow managing to kind of do things, what's going to happen? It's going to kind of say, okay, enough is enough, I'm not going to do anything. So now what is going to happen? My somehow compensated heart failure has now entered into a full-blown heart failure. So this is what is TACO. Now another important thing what you need to understand is that there is something which is called as a TRALI. What is a TRALI? So in the TRALI, what happens is that whenever you kind of given components, most commonly this basically happens after the fresh frozen plasma, right? After you give the fresh frozen plasma, so what happens is the immune system basically gets activated, interleukins and everything is kind of produced, and because of this, what happens, the patient basically is going to develop a lot of respiratory distress. Now the problem is that the TACO and the TRALI, they both can present with the respiratory, they are both going to present with the respiratory distress. So what you need to understand is that if at all the heart is failing, what is going to happen? The pulmonary edema is going to increase, and because of that, the patients are going to kind of have a respiratory distress. Now you as a physician will get confused that, you know what, whether I'm dealing with a TACO or whether I'm dealing with a TRALI. If you get an X-ray done, in both of them, you're going to have a white out lung. So that is why you basically, how do you kind of distinguish between them? With the help of a pulmonary capillary wedge pressure. So pulmonary capillary wedge pressure is going to be normal in the TRALI and it is going to be elevated in the TACO. Okay. Now the more important as far as the transfusion is kind of concerned is the TRALI. So what is the TRALI? Transfusion related acute lung injury. Now this is basically a life-threatening condition. Here the patients basically rapidly deteriorate the respiratory function and everything, and what you have to do is you have to provide the respiratory support to the patient in the form of an oxygen, in the form of an intubation, in the form of using whatever the ventilators and everything. Okay, so I hope you've understood. This is a very basic things about the TRALI and the TACO which you need to understand over here. I've covered like quite a few of the MCQs over here. I hope you've understood. TRALI is an important topic, please do understand that. Okay, now in the septic, what you need to understand, there are a few terms which is called as the SIRS, sepsis, severe sepsis, and the septic shock. All these are the bullshit, that's fine. The only thing which you really need to understand is the difference between the SIRS and the Q-SOFA scoring system. So there are two scoring systems which you really need to remember by heart. So what is the SIRS? Here the temperature, either it is kind of more than 38 or less than 36 degrees Celsius. Okay, so that is one thing. Okay, so at least two components should be kind of, two or more components should be met in order to kind of call it as a SIRS. Respiratory rate of more than 22 per minute. Please try to understand there is a difference. Okay, so in the Q-SOFA the respiratory rate is 20 per minute. So over here it is 22 per minute. Heart rate over here is more than 90 beats per minute, and here the WBC count, it should be a kind of either less than 4,000 or more than 12,000. So this is what is called as an SIRS. If at all there is a patient with an SIRS, it doesn't mean that the patient is basically having a sepsis. SIRS can happen after the trauma, after a very major surgery. So that is systemic inflammatory response syndrome. So it basically says that there is a inflammatory response which is basically going on in the body. It can be because of the trauma, it can be because of the surgery, whatever. Okay, then we have a Q SOFA. What is this particular Q SOFA? So this is a quick SOFA sepsis or whatever the assessment kind of a thing. The components of this are systolic blood pressure less than 100 millimeters of mercury. Please do not mess up. It's not less than 90. Then respiratory rate more than 20. I just told you. And the GCS, the Glasgow Coma Score, which we basically can calculate to assess the mental status of the patient, that is less than or equal to 14. Okay, so please try to understand this point. This is what you need to understand. Okay, I hope you have understood. Got it. Very, very important. Do not forget about these guys. Okay. Now sutures. Now sutures basically can be what you call as an absorbable sutures and the non-absorbable sutures. In the absorbable sutures, what you have a naturally occurring absorbable sutures and the synthetically occurring absorbable sutures. Okay. So what are the naturally occurring absorbable sutures? We have a catgut, we have a chromic catgut. The synthetically occurring absorbable sutures are the monocryl, we have a vicryl, and we have a PDS. Now what about this particular catgut and the like chromic catgut? From where is this particular catgut kind of derived? Okay, so please try to understand the catgut is basically derived from the submucosa. Okay, so from the submucosa of the intestine of the sheep. Okay, so submucosa of the intestine of the sheep. Now, why the hell it is basically derived from the submucosa? Because submucosa happens to be the toughest layer of the intestine. Okay, so this is the toughest layer of the intestine. That is why it is basically derived from the submucosa. Okay, I hope you have understood this particular point. Now, what about the okay? The problem with the catgut are two. One is absorption time. The absorption time is pretty less, 5 to 7 days or something, right? Now, another important thing is how are these particular naturally occurring absorbable sutures getting absorbed? Okay, so the naturally occurring absorbable sutures, they basically get absorbed by the process of what you refer to as your enzymatic degeneration. Enzymatic degeneration. So whenever there is an involvement of an enzyme, what is going to happen? There is going to be an exothermic reaction. Whenever there is going to be an exothermic reaction, what is going to happen? There is going to be a tissue reaction. So the tissue reaction is more with the absorbable sutures as compared to that of, naturally occurring absorbable sutures as compared to that of a synthetically occurring absorbable suture. Now, what is this chromic catgut? In the chromic catgut, what we did was we coated the catgut with a chromic acid. Okay, so what we did was we coated the catgut with the chromic acid. This basically solved the problem of the absorption time, but it was not able to solve the problem of this enzymatic degeneration because the tissue reaction was still more with this particular catgut. Okay, now what about the synthetically occurring absorbable sutures? We have a monocryl, we have a vicryl, we have a PDS. So what about this particular monocryl? Okay, so these are the what you call as a synthetically occurring absorbable sutures. What is the absorption time of the monocryl and the vicryl? It is 60 to 90 days. Okay, absorption time of monocryl and vicryl is 60 to 90 days. What about the PDS? PDS is also referred to as your delayed absorbable suture. So here it is basically called as a delayed absorbable suture, and here it is 180 days. Okay, so what is an absorption time of this? This is 180 days. Okay, I hope you have understood. Now, what about the synthetically occurring absorbable sutures? How are they absorbed? So please try to understand the synthetically occurring absorbable sutures. They are basically absorbed by the process of hydrolysis or phagocytosis. Okay, phagocytosis. So because they are basically absorbed by the process of hydrolysis and the phagocytosis, because of this, the tissue reaction is very less as compared to that of naturally occurring absorbable sutures, and that is why we prefer the synthetically occurring absorbable suture. I hope you have understood this particular point, guys. Okay, see guys, I will not be able to write everything because obviously then the lecture is going to become 10 hours and it's not going to be beneficial for you, because I hope that you are the ones who are appearing for this particular exam within, let's say, 10 to 12 days or something. So I'm just trying to revise things for you over here. Okay, so I hope the speed and everything is kind of okay with you guys. Okay, now what about this particular non-absorbable sutures? They can be either natural or the synthetic. That's fine. The naturally are silk, the synthetic are the proline and the nylon. So you also have to kind of remember the chemical names of this. Okay, so what is a vicryl? It is polyglycaprone. Monocryl is basically polyglycaprone. Vicryl is basically polygalactic acid. Then we have a proline, which is polypropylene, and nylon is basically polyamides. Please do remember these particular names as well. Now, the suture material, it can be either a monofilament and multifilament. Now, what about the monofilament? In the monofilament, the capillary action is very, very less. Okay, so capillary action is very less, and the capillary action is kind of more with the multifilament suture. Because the capillary action is kind of more, because of this, there's an increased risk of infection with the multifilament sutures. Okay, now whenever you pass a suture from any particular tissue, if at all it's a multifilament kind of suture, what is going to happen? It is going to kind of create a kind of a friction. So there's going to be a bit more tissue trauma with the multifilament suture as compared to that of the monofilament suture. What about the tensile strength? So what is the tensile strength? If you kind of pull this particular suture tangentially, at what particular strength this particular suture is going to break? Obviously, if at all there is a multifilament suture, the tensile strength of that particular suture is going to be more. Then coming to the memory, what about the memory? Memory of the multifilament suture is less as compared to that of the monofilament suture. Why so? So what you need to understand is, what is the memory? Memory is basically the tendency of any particular suture to basically go back to its kind of normal position. Okay, so that is basically going to be more with the monofilament suture, and because the memory is more, what you need to understand is the knot security is a bit less, because the sutures are going to untie itself. They are going to try to untie itself, and that is why the knot security with the monofilament sutures is less as compared to that of the multifilament suture. Okay. Okay. So multifilament basically means multiple threads. Okay. So I usually give the example of the hairs of the female. Okay. So what you need to understand is that in order to kind of manage the hairs of the females, what they basically do is they either braid their hairs. Okay. So they kind of braid the hairs, so they all act as a kind of a single unit, or you basically, or they, what they can do is they can twist their hairs. Okay. So are you understanding? So if at all you have a multiple threads, either you can, so multifilament sutures can be either braided or the twisted, because you want them to basically act as a single unit. Monofilament is basically just a single thread. Okay, so I hope you've understood. These are the basic differences between the monofilament and the multifilament suture. Absorption time and the whatever the tensile strength. So forget about this, that's all. Okay, now the suture material and the uses. So please try to understand over here at least the suture kind of uses of this particular Prolene. So Prolene is basically used for the vascular surgery, very important. Okay, for the hernia surgeries and the sheath closure. So Prolene is kind of needed whenever you kind of want that particular tissue to be kind of united for a prolonged period of time. Hernia, obviously, if you use Vicryl over there, there's going to be the recurrence of the hernia. So hernia surgery, sheath closure, you don't want the abdominal dehiscence to occur, the incisional hernia to occur. Okay, so all these particular things, these are the places where you're going to use the Prolene. Vicryl is basically called as the workhorse suture in the surgery, right? So what do you understand by this particular workhorse suture? It basically means that it is the most commonly used suture whenever we do that particular surgery. It can be used for any number of reasons: subcutaneous tissue, bowel, blah blah blah, various places. Okay, nylon for the skin closure, that's fine. PDS for the hepatobiliary pancreatic surgeries, that's all fine. Monocryl is basically for your what you call as subcuticular. Okay, for the subcuticular sutures, what you basically use is this monocryl. Okay, so I hope you've understood these particular points. Very important. Okay, right. Now, ideal time for the removal of the suture. What is an ideal time for the removal of the suture? So ideal time for the removal of the suture in the face is basically around 3 to 5 days. Okay, so please try to understand over here in the face and the lips and the eyebrows, blah blah blah, all these particular places, the ideal time for the removal of the sutures is around 3 to 5 days. Okay, so I hope you've understood this particular point, guys. Okay, now what about the scalp and blah blah blah? So you can just remember the other things as well. Scalp, it is around 6 to 8 days. Abdomen is around 8 to 10 days. Ear, back, foot, extremities, everything, it is around 12 to 14 days or something like that. Just remember. Okay, so they might not ask you this directly, but they might ask you that like this. I know after the cleft lip surgery, when do you kind of remove the suture? So after the cleft lip and the cleft palate surgery, not cleft palate per se, cleft lip surgery, when do you kind of remove the sutures? So you remove the sutures after like 3 days. Okay, so please try to understand, after 3 to 5 days you basically remove the sutures after the cleft lip surgery. Okay, scalp is basically around 6 to 8 days, abdomen is around 8 to 10 days or something like that. Okay, now there's something which is called as an ear of a suture. So what is this particular ear of the suture? Let's assume that this is a suturing which you have done. Now towards the end of the suture, what you need to do is you need to tie a knot. Okay, so you have tied a knot, and then this is a part where you basically cut the suture. Beyond the knot, you basically cut the suture. This is what is referred to as an ear of a suture. Now I understand this, you might feel that it's very less. So in real life, you basically kind of do it with a practical experience, but your Love and Bailey says that the ear of the suture should be at least 2 millimeters. Okay, so at least 2 millimeters should be the ear of the suture directly from your Love and Bailey. Then there's something which is called as the Jenkins rule. What is this particular Jenkins rule? This basically states that if at all you want to close the wound which is of the size X, okay, if at all the size of the wound is X, what is the length of the suture which you're going to need in order to kind of close this particular kind of a suture? So 4x. Okay, so you need 4x the length of that particular like if at all you want to close the wound which is of the size X, you need 4x the length in order to close that particular wound. Okay, then there is something which is called as an Aberdeen's knot. So where do you kind of use this particular Aberdeen's knot? Anybody? So you basically use it in the continuous suture. Okay, so whenever you are kind of taking a continuous suture, in that particular continuous suture, you basically have to place an Aberdeen knot so that that particular continuous suture doesn't kind of opens up very, very easily. So that is what you need to understand about this particular Aberdeen knot and the continuous suture. Okay, I hope you have understood this particular point, guys. Okay, right. Now, then we have a energy sources. So we have a monopolar cautery and we have a bipolar cautery. So, okay, so what you need to understand is that in order to kind of complete the circuit, we need kind of two kind of electrodes. Like, so what you need to understand, let's assume that this is what is a cautery machine. Okay, so what you need to understand is that the current needs to travel from this particular cautery machine into the instrument, and then it has to kind of come back also. So if at all you have a bipolar cautery which have two poles, so what is going to happen? That particular circuit is going to get completed. But if at all you are dealing with a monopolar cautery, then what is going to happen? The current is going to travel, but you have only a single probe. So here you need a patient plate. So now what is going to happen? The current is going to go through the body of the patient, and then it's going to be picked up by this particular patient plate, and then it is going to be brought back to the cautery machine. So please try to understand over here. We have a monopolar and a bipolar cautery. Okay, this is basically like a machine. It's like basically a mobile phone, right? Now, inside that you can pass either a cutting current or you can pass a coagulation current. So please appreciate the difference between that, okay? So there is a monopolar and bipolar cautery, and the current which you basically pass through it, this is what is basically your cutting current and the coagulation current, okay? So please try to understand this point. Now, what is this? This is what is your monopolar cautery. Now, what you are basically asked is that this yellow button and this particular blue button. So what is this particular blue button, yellow button? So yellow is basically for the cutting and the blue is basically for the coagulation. So as you can see over here, in the monopolar cautery, you can pass both these particular currents. If you press the yellow button, the cutting current is going to come out. If you press the blue button, what's going to come out is a coagulation current. What is this? This is what is the patient plate. As I told you, the patient plate is something which is needed in the monopolar cautery. Then what is this? This is what is a bipolar cautery. In the bipolar cautery, the only current which you can basically pass is a coagulation current. You cannot pass the cutting current through this particular bipolar cautery. Okay. Now, what you need to understand is the difference between the cutting and the coagulation current. So again, I'll not be able to talk in a bit much more detail, but what you need to understand is in the cutting current, there is a continuous flow of the current. Okay, so in the cutting current, there is a continuous flow. So because of this, what happens, the tissue basically gets heated and ultimately there's a charring of the tissues. That is why it ends up cutting that particular tissue. In the coagulation current, what happens? Only for the 6% of the time, the current basically flows. For the rest of the 94% of the time, the current is not flowing. Are you understanding my point? So when I press that particular blue button, only for the 6% of the time, the current is flowing. For the rest of the time, the current is not flowing. So what does this do? This basically allows the tissue to basically cool down. So because of this, what happens? The protein in the tissue, this basically gets time to kind of get coagulated. And that is the reason why in the coagulation current, we are able to kind of have that vessel sealing effect. And that is why the coagulation current is something which is basically used for the what you call as a hemostasis, because it is going to help in the vessel sealing effect. Okay, so I hope you have understood this particular point. Now, another important thing is the lateral spread of the current. In your mind, we always think that, you know what, the cutting current is the bad current, coagulation current is a good current, but the lateral spread of the current is more with the coagulation current. Please remember that. Okay, so the lateral spread is more with the coagulation current, the lateral spread is less with the cutting current. Please remember at least these two particular points, guys. Okay, right? Okay, okay, now what is this? This is what is your nasogastric tube. Okay, so this is what, this is a nasogastric tube. Okay, Rice tube, nasogastric tube, whatever you want to call it. What about the length? The length, how do you calculate the what is the length which is going to be used for that particular patient? So from the tip of the nose to the ears, ears to the xiphisternum. This is one of the ways in order to calculate what should be the length of the kind of that particular tube. Now, what about the best position? Like what is the best position of this particular tube? How do you kind of check for the position of this particular tube? Okay, so you might say that, you know what, you kind of push an air and you try to auscultate it in the epigastric region. Well, yes, that is one of the ways, but that is not at all a reliable way. So in your exam, what they ask you is that what is the most reliable method of kind of checking the position of this particular nasogastric tube? So as I mentioned, I'm pretty sure that some of you might be saying that, you know what, push an air and try to auscultate in the epigastric region. Well, yes, that is one of the ways, but that is not the most accurate way, not the most accurate way. The second method is that you can kind of take an X-ray. Why? Because over here, not very well visible, but what you have is a green kind of a radio opaque line, so that you can kind of detect on an X-ray, but that's fine, but that's again not the most accurate way. The most accurate way is that you aspirate the contents, and whatever the contents you basically aspirate, what you need to do is you kind of need to check it the pH of that particular content, because it's a nasogastric tube. If you push it a bit more, it is going to go beyond the stomach. It is going to enter into the duodenum, and now the contents are going to be alkaline in nature. You understand my point? So because if at all you have placed it correctly inside the stomach, whatever the contents you're going to aspirate, it is going to have an acidic kind of a content. Are you understanding? So the best method to check the position of this particular nasogastric tube is the, what you call as the aspirate the content and check the pH of that. Another question which was asked in the AIMS around 4-5 years back was, what is the best position to kind of push this particular nasogastric tube? It is in the sitting position with the neck flexed. Okay, sitting position with the neck flexed. Okay, so that is what you need to understand. Yes, Karan, I hope you have understood this point now. It is not the X-ray. Okay, what is this? This is what is the two-way Foley's catheter. Okay, Foley's catheter in order to drain the kind of a urine. What is the size of this particular Foley's catheter? Anybody? Just let me know. What is this? This is what is a silicone catheter. Okay, so what was this? This was a silicone coated but a latex catheter. This was a latex catheter. Just don't get confused. This is what is a latex catheter. What is this? This is what is a silicone catheter. Silicone catheter. Okay, but this is a three-way kind of Foley's catheter. Okay, now this is what is the color coding which you need to understand over here. So the most commonly used catheter for the males is what? It is the orange. That is a 16 French. Okay, what is the most commonly used catheter for the females? It is a 14 French. That is a green. Then we have red, which is basically 18, yellow is basically 20, purple is basically 22, all those particular stuff is there. Okay, so I hope you have understood. Please go through this particular list. This is important. Okay, then what is this? This is what is an IV cannula. This is what is the pink, what is the gauge of this particular IV cannula? Can you please help me with this? Okay, so this is what is the sizes of this particular IV cannula. Pink is basically 20, green is basically 18, blue is 22, yellow is 24. So the most commonly used IV cannula as per the ATLS. Okay, so whenever you are dealing with the patients with the trauma, what is the most commonly used kind of IV cannula? It is 18 gauge. 18 gauge. It is not the gray one, it is the green one. Okay, so that is the most commonly used IV cannula. What is the flow rate of this particular green? It is 90 ml per minute. Okay, what about the pink? 60. Okay, so please try to understand over here. Then we have 16 is basically 180, blue is 36, and the yellow is 20. So please remember the flow rates also about these particular stuff. Okay, now what is this? This is what is the surgical blades and the surgical handles which we have. So what about this particular surgical blade number 11? Okay, so what is this particular surgical blade number 11? This is also referred to as your stab knife. Okay, what is this? This is also referred to as your stab knife. What is this? 15. This is what is called as a D knife. So where do you use this particular stab knife, the 11? This is basically used for the incision and drainage, for the arteriotomy, for the tracheostomy, whenever you want to enter into that particular cavity in a very, very decisive manner. So then you basically end up using the 11 number blade. Okay, what about the 15 number blade? 15 number blade is basically used for whatever the minor procedures, or whenever you want to give a very, very precise incision. Let's say if you want to kind of remove one particular lesion on the face or something like that, then you will basically use that D knife. Okay, 15 number or the D knife. Okay, now what about this particular 20, 21, 22, 23 and all? These are basically used for the debridement. Okay, so these are basically used for the debridement. Now you cannot just take these particular things on the hand, and you cannot just kind of do that. So what you need to understand, you need to put it on the handle. So what is this particular handle? It is called as a BP handle, which is a barred Parker handle. The 11 and 15 number blades, they are basically put on the barred Parker handle number 3, and the whatever the 20, 21, 22, 23, all these particular things are put on the barred Parker handle number 4. Okay, so I hope you're able to understand this point. These can be the 3 and the 4. On the 3, what you basically put is blades 11 and 15, and in the 4 you basically put 20, 21, 22, 23, whatever. Okay, now before I move ahead, I don't know why, but I had actually charged this particular pencil, but it just showed that the battery of this particular pencil is a bit low. So what I'll do is I'll have to disconnect this particular thing in order to charge it. But during that time, I'll just have a small conversation with you. By the time this particular thing gets charged in a couple of minutes, I'll have a small conversation with you. So what you guys need to understand is that, okay, so I know that everybody will kind of keep on sharing their own particular kind of knowledge, and like they will kind of keep on giving you the advices, what, do this, do that, or something like that. I won't do that, because please try to understand that everybody tries to say with their own experiences, but what you should do is basically what resonates with you. So what I'll do is I'll just share my own experience, and rest kind of it's up to you. So what you need to understand is I always feel that it's okay to kind of, okay, obviously, like all of you might not be at the same position, right? So some of you might be kind of better prepared, some of them you might be a bit less prepared. That's all fine. But what you need to understand is whatever the level of preparation you have, whatever the level of preparation you have, you should be able to deliver that on the day of the exam. That is very, very important. So what you need to understand is, let's assume that you are the one who is basically destined, or you have prepared that you are about to get a rank of, let's say, 2000, and you end up getting a rank of 2000. That's absolutely great. But let's assume that you are about to kind of like your preparation basically says that, you know what, you are going to get a rank of around 1000 or something like that, but on the day of the exam something happens and then you end up getting a rank of 1500. Then that's something which I personally feel is not very, very fair to your efforts, your whatever the things you have kind of put in. Are you understanding my point? So relatively you have got a better rank, but you were not fair with yourself, but the person who got the 2000 rank was a bit fair with themselves. So why these particular things happen? It all boils down to, at the end of the day, silly mistakes or something like that, right? So how many times it has happened that you have given a paper and then after the paper you thought that, you know what, shit man, I did silly mistakes? Practically every time, right? And everybody does that. So if you feel that the toppers, they do not commit the silly mistakes, that's not true. Even they commit the silly mistakes, but the number of silly mistakes which they basically commit is very, very less as compared to what you do. So you might be kind of committing 20, 25, 30 silly mistakes. They might be committing, let's say, 4, 5, 6, 7 silly mistakes. Now, what are the ways in which you can reduce the silly mistakes? One is better preparation. The time is practically gone now. The exams are just like a week or so from now. But let's not talk about that. Let's talk about what you can do at this point of time. Right. So we always have a fear, right? What if I don't get a rank? What if I am not qualified or something like that? And sometimes this particular pressure becomes so heavy that it basically becomes counterproductive. You are not able to kind of work, you're not able to kind of read, and then your mind basically wanders, even if you're with books for, let's say, 6 years of the time, but the effective reading was only for, let's say, 1 hour or so. Okay, so all these particular things are absolutely counterproductive. And a point comes when you feel that, you know what, let's get done with this particular exam. Whatever has to happen has to happen. It's okay. Let's get done with this particular exam. So that particular phase is something which is not kind of good. So some amount of tension is good. That basically increases your productivity. But if you get really overburdened with this particular kind of tension, that's going to kind of screw you up. So what I would suggest is just, it's okay. What's the worst going to happen? You will not get selected. That's not the end of the life. You will still do, like, you will attain what you are destined to attain in this particular life. So don't worry about it. You will do whatever, like the things will kind of fall into place and you will kind of do. So first of all, just forget about this particular fear that, you know what if I'm not able to clear this? What if I'm not able to kind of score good marks? What if I get disqualified or something like that? You are taking extra tension is not going to help you in any way. It is, at the end of the day, it is just going to be a bit counterproductive. Lastly, on the day of the exam, what you should do on the day of the exam, you should be very much be present on that particular day. So various great people have kind of conveyed this in their own format. Will Smith conveys it in a different format. Harsha Bogli basically conveys it in a different format. Will Smith basically says that, you know what, if you want to build a very, very good wall, then what you should do, you should kind of place every brick to the 100% of your capacity. So at the end of the day, you are going to kind of be giving 100% to that particular wall, and ultimately that particular wall is going to be very, very good. Okay, so that's one version. Another version is Harsha Bogli basically says that it's really not about the number of overs, it's basically about every ball. So if at all a player basically gives 100% to that particular ball, at the end of the day, you have given 100% to the entire kind of a match. So similarly, right, it's really not about the number of questions which you have. If you give your 100% to every question which you basically have over there, that is what is going to be beneficial for you. Okay, so it really doesn't matter that first 5 questions were so bad that you were not able to answer it even slight bit. So when you're on the 6th question, stop worrying about the first 5. It's all okay, they're okay. Like some difficult questions are asked, it's okay. You're thinking about those particular questions is not going to change your present scenario. So it might sound very, very silly, but when you are on that particular question, be on that particular question. Why do you commit a silly mistakes? Because you feel that, you know what, this particular question is very, very simple. Let's kind of, oh, yeah, answer it. Okay, you mark it and you kind of move on. And then when you come out of the kind of examination hall, you feel that, you know what, it was such a simple question, how I could do it wrong. In your mind, what basically goes is that, you know what, let's kind of finish the papers fast so that I can focus and give that particular time to difficult questions or which I was not able to answer or something like that. So I'm not trying to say you to waste time over those particular questions, but give the due time which is kind of needed. And when on that particular question, just focus on that particular question. Do not kind of think about XYZ things. Don't think about, oh, I'm going to go out tomorrow and, you know, whatever XYZ or something like that. I understand my point. Be on that particular day, be on in the examination hall, be in that particular question. That is going to help. bit. Okay, so these are just my couple of bits, and you are wise enough, and about the revision and everything, whatever I say, it's not going to change your course at this point of time, so it's okay. Whatever you have been doing, just do that, just consolidate whatever you have read and just deliver what you deserve. Okay, so please just go and take what you actually deserve. Okay, so don't let that particular slide away from you just because of getting overburdened or not being present on the exam. I hope you are understanding what I'm trying to tell you over here. Okay, hopefully now this is charged. Let's see. And yeah, I'll just connect my iPad again and we'll start back. Okay, yep, right, just give me a minute, guys. Okay, guys, yeah, so let's move ahead. Okay, now let's talk about this particular deep venous thrombosis. So now we are going to talk about what you call as a venous system. So what is the deep venous thrombosis? Again, the problem with the deep venous thrombosis is an immobilization. So if at all the patient is basically not moving around, so what is going to happen is that the blood flow, the blood will not come back from the lower limbs to the heart and everything. And because of this, there's going to be the venous stasis, and because of that, the patients might end up what you call as a deep venous thrombosis. So what you need to understand is that in our lower limbs, there are two venous systems. There's a superficial veins and there's a deep veins. So if this particular thrombosis develops inside the deep veins, that is the femoral or the popliteal veins, that is what is referred to as your deep venous thrombosis. Okay, so what is going to be the presentation of this particular deep venous thrombosis? The presentation of the deep venous thrombosis is basically going to be the pain and the tenderness. Okay, so the pain and the tenderness, this is what is the major presentation of the deep venous thrombosis. Okay, pain in the lower lips and swelling of the calf and the tenderness. Okay, now investigation of choice, very important. What is an investigation of choice for the deep venous thrombosis? It is a duplex scan. Okay, the duplex scan, that is what is an investigation of choice for your deep venous thrombosis. Okay, what is a major complication because of this? So you are really worried about that, whether that one part of that basically thing is going to get dislodged. It might go to the kind of heart, and then it might go to the lungs, leading to pulmonary embolism. So pulmonary embolism, if at all the embolism is very big, so patients might land up into something which is called as a saddle embolism. Because of this, the patients might become hemodynamically unstable, and because of this, the patients may kind of even lose their life. But if at all there is a smaller embolism, what is going to happen? It is going to go to the periphery of the lungs, and because of this, the patients are going to have what you call as a chest pain and the hemoptysis and the pleuritis or something like that. Okay, so very small part of the lung is going to get infarct if at all you're dealing with a small embolism. But per se, the pulmonary embolism is something which is not kind of good, right? And that is why we kind of try to prevent it. Okay, so how do you kind of prevent it? How do you kind of treat it? Okay, how do you prevent the pulmonary embolism? You ask the patients to not move around. Okay, so if at all there is a patient who's having a deep venous thrombosis, you ask the patients to take a bed rest, and then you have to kind of treat that. How do you kind of treat that? So you basically start the patients on the low molecular weight heparin and the warfarin. So what you need to understand is the warfarin, it's going to take around 3 to 5 days for its effect to kind of come. So you start the patients on both low molecular weight heparin as well as the warfarin. Now, how do you look for the efficacy of the warfarin? So for the efficacy of the warfarin, what you have is a PT-INR. So what is your target INR? The target INR is basically around 2 to 3. That's what you want to achieve, right? Now, once you achieve that particular target INR, now you can shift the patients from the low molecular weight heparin to the warfarin. But that is what is going to take around 3 to 5 days. Okay, so please try to understand this particular point. So what is the target INR we are basically kind of looking for is 2 to 3, but this is going to take around 4 to 5 days, and that is why you start the patients on both low molecular heparin and the warfarin. Now, why should you convert the patients from the low molecular heparin to the warfarin on the first place? Because warfarin is an oral medication, okay, and you have to kind of continue the treatment for this for around 3 months. So it is better if you can kind of give the oral medications to these particular patients. Finally, how do you prevent this particular deep venous thrombosis? So for the prevention of the deep venous thrombosis, you have a mechanical and the pharmacological kind of methods. Mechanical means the pneumatic compression stockings, that you basically put it during the surgery, and even after the surgery in the ICUs and in the HTU units, you basically put the patients on this particular pneumatic compression stockings, and then you have pharmacological treatment. So what you basically give in this particular pharmacological treatment is LMWH, enoxaparin. That is what you basically give. Now, which is better, pharmacological method or mechanical method? Which is better in order to prevent the deep venous thrombosis? Pharmacological. Okay, pharmacological method is kind of better as compared to that of the kind of physical. Okay, but what you do in the real life, you basically give both. Okay, you give both simultaneously. Now, let's talk about this particular varicose vein. So, what is a varicose vein? What is the definition of a varicose vein? Varicose vein basically is a dilated, tortuous, elongated. How much dilatation? More than 3 millimeters. Okay, so please try to understand what is a varicose vein. Varicose vein is basically dilated, tortuous, and elongated veins. Okay, dilated, tortuous, and elongated veins. Dilatation has to be more than 3 millimeters. Okay, now we need to understand the basics of the anatomy. So, what we have is we have a superficial venous system, we have a deep venous system, and then we have a perforators. Now, inside all these particular veins, what you have is the valves. What is the characteristic thing about the valves? Valves allow the flow in one direction, allows the flow of the blood in one direction itself. Okay, so our superficial veins have valves, our deep veins have valves, our perforators have valves. So what you need to understand is that this varicose vein is basically formed because the valves are not functioning in a good manner. The valves are not functioning in a decent manner. Because of this, what you basically have is this particular varicose vein, right? Right now, okay. So I hope you have understood these particular points, guys. Right now, what are the named perforators? So in our legs, we have, let's say, hundreds of perforators, but there are a few named perforators. So what are these particular named perforators? We have a May and Kutzner. Then we have a Cockett's perforator. Then we have a Boyd's perforator. And we have a Dodge perforator. May and Kutzner are the ankle perforators. This Cockett's is basically present for like 5, 10, and 15 centimeters from this particular medial malleolus. This Boyd's is basically called as an around knee perforator. Once they had asked you this, okay, once they had asked you what is an around knee perforator, can you tell me the around knee perforator? The answer was Boyd's. Okay, Dodds is basically the above knee perforator. Dodds is above knee, Boyd's is around knee perforator. Okay, so I hope you have understood this point. What is the clinical features of these particular varicose vein? So over a period of time, what is going to happen? The patients are going to have edema. Patients are basically going to have hyperpigmentation, lipodermatosclerosis, and the venous veins and something like that. So what you need to understand is, okay, so I will take a chance to kind of write these particular things for you guys. So what you need to understand is this is also going to help you understand and remember the CEAP classification in a good manner. So what you need to understand is that like you and I are the normal individuals. So we do not have any particular varicose veins. So these are the normal individuals. Now these particular patients, what can happen here? Like we can develop a dilated vein. So the dilatations can develop and the dilatations can be less than 3 millimeters. Will you call it as a varicose vein? No. This is what is a reticular vein. Okay, if at all the dilatation is less than 3 millimeters, this is what is referred to as your reticular vein. Now please pay attention towards this. This is what is going to help you in remembering the C stage of the CEAP classification in a good manner. So please pay a bit of attention over here. Okay, then what can happen over a period of time? The patients are going to develop a varicose vein. Okay, so the proper varicose vein basically develops, but these particular varicose veins are asymptomatic at this point of time. Okay, so they are asymptomatic. Okay, then what can happen? The symptoms will start to appear, and what is the first symptom which is going to occur? The first symptom which is going to occur is an edema. So patient basically develops edema. Now even at this point of time, if at all the patients do not get treated, what is going to happen? Through these particular blood vessels and everything, some RBCs are basically going to come out, and these particular RBCs are going to get destroyed. Okay, RBCs are destroyed, and what is basically coming out of these particular RBCs is the hemoglobin. So will this hemoglobin will be responsible for the pigmentation? The answer is no. This hemoglobin will be converted into hemosiderin. Okay, hemosiderin, and this hemosiderin is the thing which is basically responsible for the skin pigmentation and the eczema. So this particular hemosiderin is something which is kind of responsible. At the same time, what can happen is WBCs can also come out. So these particular WBCs, what they are going to do, they are going to cause an inflammation and everything, and because of this, the patients are going to develop a lipodermatosclerosis. So patients are basically going to develop lipodermatosclerosis. Even at this point of time, if at all the patients are not treated and something like that, ultimately what can happen is the ulcers can develop, and the ulcers can be either an active ulcer or it can be a healed ulcer. Okay, so they can be an active ulcer or they can be healed ulcer. So now I hope you have understood this point. Very, very simple. Okay, normal individuals, dilated vein, that is the reticular vein or the telangiectatial, then asymptomatic varicose vein, edema, then what we have is the skin pigmentation, then we have a lipodermatosclerosis, then we have an active ulcer and the healed ulcer. Now this is what is a C0. Then dilated veins, reticular veins, this is what is a C1. Varicose vein is basically C2, edema is basically C3, skin pigmentation is C4A, Lipodermatosclerosis is C4B, then healed ulcer is basically C5, and an active ulcer is basically C6. Are you understanding my point? So what I've written now, this is what is a C stage of a CEAP classification. If you remember the patients like this, you will, like, there's no mnemonic, nothing needed to understand and to remember this particular C stage of the CEAP classification. I hope you have understood this particular point. Very, 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 very important. Okay, right? Now, what is this? Very, very important. This is what is the venous ulcer, characteristic venous ulcer, which is basically occurring in the gaiter area. What is this particular gaiter area? So gaiter area is basically the medial, like the lower 1/3 of the medial side of the leg. What is this particular gaiter area? Lower 1/3 of the medial side of the leg. This is what is the gaiter area, and here what you're basically having is a venous ulcer. What is this? This is what is a venous ulcer. Do not kind of mess up with this particular image. It's a very, very important image, can be asked to you. What is this? This is what is a lipodermatosclerosis. So what kind of an appearance do you basically get over here? Lipodermatosclerosis. So here what you basically get is this inverted champagne bottle appearance. What you basically get is an inverted champagne bottle appearance in the lipodermatosclerosis. Okay, I hope you have understood this particular point. This is what is the CEAP classification. We just talked about that. I hope, and the most important thing about this is this particular stage. So you can just go through it. I'll not repeat it, but I hope you have understood this particular point. So this is what is the CEAP classification. You should remember the other things as well, like the E basically stands for etiological, A basically for the anatomical, P for the pathophysiological. But the important in the depth, what you basically need to remember is the C, that is the clinical stage of the CEAP classification. What about the diagnosis? So you can have a clinical test. Let's not go over there. There's a Brudley-Todenberg test, and we have a Fekans test, and there are n number of other tests. Let's not kind of go over there. But the investigation of choice is a Doppler study, duplex scan Doppler study, which we just saw in the DVT, the same kind of a thing which basically use over here. For the treatment, if at all there is a defect in the valves in the veins, okay, in the veins, if at all there's a problem with the veins, we have a Trendelenburg's operation, which is what is an open operation, or you can have a minimal invasive kind of approaches like EVLA and the radiofrequency ablation. What is an EVLA? It is an endovascular laser ablation. With the help of a laser, you can kind of burn the walls of the vessels, and then you can kind of bring them together so that they basically coalesce, and that particular that particular vessel basically seals off. Okay, then defect in the perforator. If at all there is a defect in the perforator, then what you have is the Cockett's and the Dodds operation and the SEPS. That is a what is SEPS? It is subfacial endoscopic perforator surgery. So please remember this. This is what is an image of a SEPS. So this is like you try to kind of put what you call as a endoscope wherever you want. Like we surgeons are obsessed with the endoscope, so we keep on putting it wherever we want. So this is what is doing a varicose, like the surgery with the help of a endoscope when the defect basically is in the perforator. So this is subfacial endoscopic perforator surgery. Okay, now before moving ahead, so nerve damage and its symptoms. Okay, so what you need to understand is that these particular in our body, what we have is a neurovascular bundles. They basically go hand in hand. So we have a great saphenous vein, we have a short saphenous vein. They are basically accompanied by the kind of a saphenous nerve and the sural nerve. So what you need to understand is that obviously, if at all you are going to do this particular what Trendelenburg's operation, if you kind of, this is what is the stripping of the vein. So during the stripping of the vein, the saphenous nerve can get kind of injured. Okay, so that's what you need to understand. Symptoms during the surgery, nothing like that. But that is why you kind of prevent the stripping only just below the knee joint. You do not come till the calf level. So that is what you need to understand. Another important thing from the anatomical perspective, which you should remember, is the great saphenous vein. It is basically on the medial side of the leg, that's fine. But does it originate from the anterior to the medial malleolus or posterior to the medial malleolus? So it basically originates anterior to the medial malleolus. This is something which you need to remember. Okay, so I hope you've understood. Now let's talk about the arterial diseases. So in the arterial diseases, the first thing which we are going to cover is the peripheral vascular disease, which is called as the Burgess disease. Okay, so like in like we have a Burgess disease, atherosclerosis. Let's kind of focus on the Burgess disease. Now, what you need to understand about this particular Burgess disease, what is the cause? Smoking. Okay, so one only important cause of this particular Burgess disease is the smoking. Okay, so smoking is the most important cause of that. What is the pathogenesis? Blah blah blah. Forget about all these things. So here, what you happen is that here there's involvement of a artery plus the vein plus the nerve. So what happens actually is that there is a angiitis, there is an inflammation of the arteries, and whenever there is an inflammation of the arteries, what is going to happen? Whatever the nerves and the veins are basically surrounding it, they are also going to get involved because of this. Are you understanding my point? So please try to understand this point. In the Burgess disease, what you basically get is you get involvement of the arteries plus the veins plus the nerves. All these three things are basically involved in the Burgess disease. Now, what is the clinical features of these particular patients? So, what is the most important clinical feature? We have a Raynaud's phenomena and we have an intermittent claudication. So, these are the two important clinical features. Raynaud's phenomena. What is this particular Raynaud's phenomena? So, here there's a sequence of the events which basically takes place. So, earlier there is a pallor, then there is a cyanosis, then there is an erythema. So, why these particular things occur? If at all there is a cut-off of the blood supply to any particular part, what is going to happen? There's going to be the pallor. Then, over a period of time, the CO2 will get accumulated over here. There's going to be the cyanosis. Because of that, the local effects and everything, the blood flow to that particular area is going to increase, and ultimately the patients are going to have erythema. Okay, so I hope you have understood this particular point. This is about the Raynaud's phenomena. This is not specific for the Burgess disease. This can happen with a lot of other connective tissue disorders, and with SLE, scleroderma, all these particular places, you do get this particular stuff. But the important thing, the characteristic thing about this particular what you call as peripheral, like PVD or whatever the Burgess disease is, intermittent claudication. So what is this particular intermittent claudication? This is basically the cramp-like pain which you basically get in the legs when you basically start to walk. So this is what is referred to as your intermittent claudication, cramp-like pain in the lower legs. Okay, so this is basically happening because of the muscle ischemia, and yeah, that's what you need to understand over here. Now there is something which is called as a Boyd's classification. So what is this particular Boyd's classification? So when the patient basically starts to walk, and once the patient basically gets the pain, what is going to happen? Okay, so when the patient continues to walk, the pain basically goes away. This is what is a Boyd's one. So why does this happen? So once the patient started to walk, the patient got a pain, and what happened? Because of the local factors, the blood flow to that particular area got increased, and whatever the toxic metabolites were there, they got washed away, and that is why the pain basically disappeared. This is what is a Boyd's type 1. What is a Boyd's type 2? Patient starts to walk, patient gets the pain, but the patient continues to walk because the pain is not that severe. Okay, so please try to understand. For example, at this particular time, the lecture is kind of still bearable, and that's why you're over here. If at all it was unbearable, you would have kind of gone away from here. So this is what is a Boyd's type 2. Here, what happens is when the patient starts to walk, patient gets the pain, but the pain is not that severe. The patient can continue to walk with that particular pain. What about the pain, like Boyd's type 3? Here, what happens is that when the patient starts to walk, the patient gets the pain, but the pain is very, very severe. Now the patient cannot walk. Now patient says that, you know what, I have to kind of sit down, I have to take rest, and once the patient takes rest, the pain basically goes away. What about the Boyd's type 4? Here the patient have not even started to walk. The patient is basically having rest pain itself. So that is what is a Boyd's type 4. Okay, so I hope you have understood this point. This is what is the Boyd's type 4. Now, what is the investigation of choice? Many students, as a knee-jerk response, they basically say that the investigation of choice is the duplex scan. No, not really. The investigation of choice is angiography. Please remember this particular point, guys. Okay, so do not mark it as what you call as a duplex scan or anything. The investigation of choice is an angiography. What do you get in this particular angiography? So you get a characteristic corkscrew collaterals. Okay, so what you basically get is a corkscrew collaterals. Okay, so this is what is a corkscrew collaterals, which you basically get in the angiography. What about the treatment? So conservative. Ask the patients to stop smoking. You can give the patients calcium channel blockers. You can give the patients pentoxifylline. All these particular things can be tried, but they're not that effective. Stop smoking. That is the least the patients can do for themselves. Then the treatment is lumbar sympathectomy. What do you understand by the lumbar sympathectomy? So the rationale is that if at all you do a lumbar sympathectomy, what is going to happen? The sympathetic tone of that particular limb is going to go down, and whatever the blood was being taken away from the skin will be redirected towards the skin, and whatever the necrosis and the ulcers which were forming because of this, they are going to get reduced. But just remember these two statements, very, very important. Okay, three statements rather. If I tell you that, you know what, lumbar sympathectomy is the treatment for the Burgess disease, the answer is yes, it's kind of a true statement. But if at all the predominant symptom of the patient is intermittent claudication, okay, if at all the predominant symptom of the patient is intermittent claudication, lumbar sympathectomy is contraindicated, because that is what is going to increase the symptoms. Okay, so lumbar sympathectomy is contraindicated if at all the predominant symptoms of the patient is intermittent claudication. If at all the predominant symptom of the patient is what is called as a necrosis or an ulceration, or if at all the patient is having a critical limb ischemia, then in that particular scenario, yes, the lumbar sympathectomy is something which is basically done. Okay, so I hope you have understood this particular point, guys. Okay, now let's talk about the aneurysm. So what is an aneurysm? Aneurysm is basically dilatation of the vessel. Okay, so it can be a true or a false kind of aneurysm. What do you understand by the true aneurysm? In which all the layers of the vessel are basically dilated. That is what is a true aneurysm. What is a false aneurysm? All the layers are not dilated, only like one or two, like let's say the intima, or let's say only on like all the layers are not dilated. That is what is a false aneurysm. Okay, then there is a dissecting aneurysm. Dissecting aneurysm means that the blood has basically entered into the media, and with every and over a course of time, it is basically like dissecting that particular media even further. So that is what is called as a dissecting aneurysm. So we have a true aneurysm, we have a false aneurysm, and we have a dissecting aneurysm. Logically, dissecting aneurysm is basically a type of a false aneurysm itself. Okay, so it's not like a third category, it is a basically type of a false aneurysm itself. You can go these particular one-liners. So most common site of the aneurysm, let's forget about it. So yeah, so like the most common site of the aneurysm overall is the circle of Willis. The most common site of the aneurysm, extracranial side of the aneurysm, is the abdominal aorta. To be specific, infrarenal, below the origin of the renal artery. That is what is the most common site of a extracranial aneurysm. So just these 2 points. Okay, what is the most common site of a visceral aneurysm? That is a splenic artery. What is the most common site of a peripheral aneurysm? That is what is a popliteal artery. So just remember these 4 statements. That is something which is going to be sufficient. Okay, now we will talk about this. Okay, so when do you operate? So just remember, abdominal aortic aneurysms are operated if at all the size of those particular aneurysms goes beyond 5.5 centimeters. Okay, so please remember that. Okay, abdominal aortic aneurysms are operated if at all the size or the diameter of those particular aneurysms is more than 5.5 centimeters. Okay, so very, very important over here. Okay, right, now let's talk about the abdominal aortic aneurysm. So what about this? So abdominal aortic aneurysm, the most common cause is what? This process, atherosclerosis. Okay, atherosclerosis. That is what is the most common cause of your abdominal aortic aneurysm. What is the most common site? As I just told you, it is an infrarenal abdominal aorta. Infrarenal abdominal aorta. This is what is the most common site. What is the symptom? So per se, the abdominal aortic aneurysm, they do not have any major symptom. The patients are just going to have some kind of a backache, some whatever dull aching, backache, or something like that. But the problem is that they can rupture, and if at all the ruptures, the patients are going to die because of the exsanguination. The patients are going to bleed to death. Okay, that is what is the major fear. So when do you suspect that the rupture has happened? If at all there is an acute onset pain, or if at all the patient becomes hemodynamically unstable, or there is a severe pain in the back, or the sharp pain, or something like that. Okay, are you understanding? So all these particular things basically tell you that, you know what, probably there is a rupture. So if at all there is a through and through rupture, the patients are not going to come to you in the hospital. The very fact that the patients are basically sitting in front of you and you're suspecting that the patients might have a ruptured aortic aneurysm, this basically states that it is a confined rupture. Okay, sometimes the rupture happens, but it is confined by the surrounding kind of a tissue, and that is what is the only scenario where you will be examining this particular patient. But otherwise, the patients are going to die within a couple of seconds. Okay, if at all the abdominal aorta basically ruptures. Okay, surgery, right? So yeah, so if at all there is a patient who is having a particular the suspected rupture, obviously the surgery has to be done. And per se, if there is an asymptomatic abdominal aortic aneurysm, you basically do the surgery when, if at all the size is more than 5.5 centimeters. Now, can you please tell me how does this particular magic figure of 5.5 centimeters came? Who came and told you that, you know what, once this particular aneurysm is 5.5 centimeters only, then you're going to operate? So this was basically like people got to know that with a lot of research and whatever the studies and everything, because before this, it is not going to be kind of a like the risk to benefit ratio of operating is very, very less, because it's not a very small surgery, it's a major surgery. And if at all the size of the abdominal aortic aneurysm is less than, let's say, 5.5 centimeters, the chances that it's going to rupture is very, very less. But beyond this particular point, the chances of the rupture are very high, and that is why you have to kind of what you call as operate, right? That's what you need to understand. Now the mortality kind of rate, forget about this, so that's fine. Okay, so even after you kind of do the surgery, even if there is what you call as an elective surgery, even if you kind of do an elective surgery, there is 5% risk of mortality. Okay, 5% risk of mortality. In the emergency surgery, there is around 50% risk, but all these are the numbers. Let's not kind of get carried away by these things. Important things which you need to understand is most common site, infrarenal abdominal aortic aneurysm, infrarenal abdominal aorta. And what is the size on which you operate? 5.5 centimeters. What is this? The CT scan, you can just kind of have a look at this. this? What is this? This is what is a dissecting aortic aneurysm. So are you able to appreciate this? This is what is an intima, which is basically being dissected because of the whatever, and the white colored thing which you're basically seeing is a contrast. Okay, so this is what is an arch of aorta. So this is a dissecting aortic aneurysm of the arch of the aorta. This is what is an angiography. Yeah, that's fine. Aortography rather. Okay, now dissecting aortic aneurysm, here the predisposing factor. So Rishabh, please try to understand, here the predisposing factor is going to be your hypertension. Okay, for the presence of the abdominal aortic aneurysm, it was atherosclerosis, but over here the predisposing factor is going to be the uncontrolled hypertension. The presenting feature, what is going to be the presenting feature? The patients are going to give you a characteristic history that there is a severe chest pain which is radiating to the interscapular region. Okay, so there is a severe chest pain which is basically radiating to the interscapular region. So that is what is going to be the characteristic history of these particular patients. Okay, severe chest pain radiating to the interscapular region, dissecting aortic aneurysm. What about the diagnosis over here? So for the diagnosis, if at all the patients are basically stable, then you basically have to perform a CT angiography. Okay, this is what is an investigation of choice rather. Okay, what is this? This is what is an investigation of choice. Obviously, first you're basically going to evaluate the patients based on what you call as a history and everything. But yeah, the investigation of choice is going to be the CT angiography if at all the patient is stable. If at all the patient is unstable, then what you need to understand is that, yeah, transesophageal echocardiography. That's what you have to kind of do over there. Okay, now on the X-ray, what you're going to find? On the X-ray, you're going to find a widened mediastinum. So that is something which you should remember. It's not very specific because widened mediastinum can happen because of a number of kind of reasons. But yes, on the X-ray, what you might get is a what you call is a widened mediastinum. Now there are two classification systems for this. What you need to understand is there's something which is called as a DeBakey's classification, and there's something which is called as a Stanford classification. So what you need to understand is, let's assume that this is the arch of the aorta and everything. If at all there is a dissecting aneurysm which is basically involving the ascending aorta and the descending aorta together, this is what is a DeBakey's type 1. Okay, this is what is a DeBakey's type 1. In the DeBakey's type 2, what happens is that only the ascending aorta is involved. This is what is a DeBakey's type 2. Okay, and then if at all only the descending aorta is involved, this is what is a DeBakey's type 3. Okay, so I hope you have understood this particular point. DeBakey's type 1, ascending aorta and the like arch of aorta and the descending aorta, everything is kind of involved. DeBakey's type 1. Type 2 may only the ascending aorta is kind of involved, and the type 3 may, what is you need to understand, only the descending aorta is involved. Okay, so this is what is about the DeBakey's classification. What about the Stanford classification? In the Stanford classification, what you need to understand is that in this, if even a small part of the ascending aorta or the arch of aorta is involved, that is what is a Stanford type A. So DeBakey's type 1 and 2 are going to be a part of your Stanford type A, and the descending aorta is going to be a part of your Stanford type 2. Type B rather. Okay, now just give me a minute. Okay, ascending involves surgery. Yeah. So what you need to understand is the management is based on the Stanford classification. So if at all you have a Stanford type A, where even like ascending aorta or the arch of aorta is involved, then definitely it needs a surgery. But if at all there is a Stanford type B, you can try a medical management, but if at all it fails, ultimately the surgery will be needed. But in the Stanford type B, you can try a medical management. So that's what you need to understand over here. Now, there was one question in which the scenario was of a Stanford type A, and then the options there was start propranolol and then do a surgery, like emergency surgery. That was the answer, guys. It doesn't mean that in the Stanford type A, you're not going to give the propranolol. Okay, so yes, as Satyajaya is kind of telling us, propranolol is given, yeah, in order to control the blood pressure, you give that. Doesn't mean that in the type A, you're not going to give. But in the type A, you're not going to delay the surgery. It is going to be an emergency surgery. In the type B, you can give the kind of antihypertensives and you can observe. If at all the patient becomes stable, then you can kind of continue with the conservative management. Okay, I hope you have understood this particular point. Now, lastly, let's talk about the thoracic outlet syndrome. What is this particular thoracic outlet syndrome? So you have a thoracic outlet. So here what happens is that the arteries and everything to this particular upper limb are basically given through this particular thoracic, like they basically come out of this and they are basically supplied to the upper limb. Now, due to XYZ reason, if at all that particular space is becoming narrowed, that basically leads to a thoracic outlet syndrome, right? So this can happen because of a number of reasons. So for example, some kind of an anatomical problem. So for example, there is a cervical rib. There is an extra rib, that is what is a cervical rib. What is a cervical rib, by the way? This is nothing. This is basically the C7 transverse process. Okay, so what we have is we have a C7 transverse process, which is basically kind of coming forwards, and that is what is your like cervical rib. Okay, so that is what you need to understand. So fibrous extension of the C7 transverse process. Now, this is not the most common cause. The most common cause is the weakness of the scalenus muscle. Because of the weakness of the scalenus muscle, this particular thoracic outlet basically becomes narrower, and that might lead to a thoracic outlet syndrome. What are the types and symptoms? So what you need to understand is it can be either arterial, it can be venous, or it can be neurogenic. Okay, now which is the most common out of all these particular stuff? Which is the most common out of all these particular things? So please try to understand. The neurogenic is the most common one, and in the neurogenic, what you need to understand is the most common nerve root which is involved is basically C8T1. Okay, so C8T1 nerve root is the one which is most commonly involved, and what you need to understand over here is that is what is basically the ulnar nerve distribution. So that is why the patients basically complain of the pain on the medial aspect of the arm and the forearm and everything, and then there is a weakness of a hypothenar eminence are basically getting there's a hypothenar atrophy, and then the little finger and the medial aspect of all those particular things. So ulnar nerve distribution is the one which is going to get affected. What about the diagnosis? So here what we have is the provocative tests. So what are these particular provocative tests? We have a Scalini test, which is basically you ask the patients to kind of hyperextend that particular limb and look on that side, and then you try to palpate. If at all the pulsations basically get reduced, that is what is one of the provocative tests. Then we have a Ross test. In the Ross test, what you basically do is you ask the patients to kind of lift the hands, and then the patient basically you ask the patients to kind of do open and close the list for around 10 minutes, and if at all the patient gets fatigued, this is what is a positive test. So that is what is a Roos test. This is also called as the East test, which is extended arm stress test. Then you have a Wright's hyperabduction test, where you basically ask the patients to lift the arms above the ears or something, and then you basically look for the pulsations. And then there is a Halstead's test, where you ask the patients to go into the military position. So all these are the provocative tests which you basically use in order to diagnose the patients with thoracic outlet syndrome. The treatment for these particular things is physiotherapy. Primarily, it is basically based on the physiotherapy, and if at all, let's say there's some kind of an anatomical abnormality, then you can kind of correct that. Okay, so you can kind of remove whatever the ribs or something like that, if at all there is some anatomical abnormality. But predominantly, as I told you, that the major reason for this is the weakness of the scalenus muscle, and that is why the physiotherapy is the primary treatment for this particular thoracic outlet syndrome. Okay, so I hope you have understood these particular points about the thoracic outlet syndrome. Okay, so that brings us to the end of your vascular system as well. Now what we are going to do is we are going to talk about what you call as a kind of a thyroid. Now in the thyroid depends on, so basically treatment depends on treatment. No, so basically the I think you were trying to say that the treatment depends on the cause. Yes, right. So see, physiotherapy is going to be needed in every patient because the scalenus muscle weakness always kind of is there. No, okay. So what you need to understand is that there's something which is called as a Paget-Shorter syndrome. What is this particular Paget-Shorter syndrome? I'm pretty sure that you would have read about this. Okay, so what is this? That there is because of the venous stasis into this particular subclavian vein, what happens is that the thrombus basically develops over there, and in this the clinical scenario will be that the patients are basically having recurrent episodes of pulmonary embolism. Are you understand my point? So yeah, the treatment is going to depend on the symptoms, but the symptoms are going to be more or less the same, right? It really doesn't matter whether you have a venous thoracic outlet syndrome or the arterial or the neurogenic. You have to understand the cause of the thoracic outlet syndrome. Either it is some kind of an anatomical abnormality, whether there is a cervical rib or there is a malformed first rib or something like that, or there is a scalenus muscle weakness. So physiotherapy is going to be there in every kind of patient, but if at all you're having a cervical rib, then obviously you'll have to kind of remove it. But along with that, let's assume that the predominant symptom is the venous thoracic outlet syndrome. Then you have to kind of ensure that you give the patient an enoxaparin and everything, and you take care of whatever the thrombus is present in this particular subclavian vein. I hope you have understood this particular point, guys. Okay, right? Satya, I hope you have understood this point. Now let's talk about the thyroid. Now what you need to understand about the thyroid is that we have this particular, let's assume that this is what is your thyroid gland. Okay, so what we have is we have the arterial supply to the thyroid. So from this particular external carotid artery, what we have is a superior thyroid artery. Then what we have is an inferior thyroid artery from this particular thyrocervical trunk. Okay, so we have this particular kind of inferior thyroid artery. So we have two major arteries. Don't talk about the thyroid artery, that's fine. this can be present in the few patients which is supplying the isthmus, but not that important one. Then we have a veins. We have a three kind of thyroid veins. So superior and the middle thyroid vein basically goes into the external jugular vein, and this particular goes into the brachiocephalic trunk. All those particular things are fine. Then we have a nerves. Okay, so what we have is we have an external branch of the superior laryngeal nerve, which is also called as an external laryngeal nerve. Now the important thing is that it supplies only one muscle. So which is the muscle which is supplied by this external laryngeal nerve? It only supplies cricothyroid. Okay, so it only basically supplies the cricothyroid. So what is this particular cricothyroid? This is the only tensor of the vocal cords. Okay, so this is the only tensor of the vocal cords, and if at all there is injury to this particular external laryngeal nerve, what is going to happen? The pitch of the voice is going to kind of go down. Do not mark it as the hoarseness of the voice, guys. Okay, please do not mark it as a hoarseness of the voice. What's going to happen is that if at all there is an injury to this particular cricothyroid, what is going to happen? That is what is going to kind of lead to what you call as your loss of the pitch of the voice. Okay, then what we have is a recurrent laryngeal nerve. Okay, another thing what we basically have is a recurrent laryngeal nerve, which is basically supplying all the other muscles of your kind of a larynx. Okay, so that is what you need to understand over here. It is basically supplying all the other muscles of the larynx. Okay, so this is the very basics of it. Then we have two effects. One is basically called as a Wolff-Chekhov effect and the Jod-Bessetov effect. So one is basically iodine-induced hyperthyroidism. One is iodine-induced hypothyroidism. What is what? Okay, so Wolff-Chekhov effect is iodine-induced hypothyroidism. So I still remember it. Wolff cutoff. Okay, Wolff cutoff. Okay, you understand my point? So Wolff cutoff is basically, yeah, so this is basically like that. Okay, so Wolff-Chekhov is basically Wolff cutoff. That basically leads to iodine-induced hypothyroidism. Jod-Bessetov is basically iodine-induced hyperthyroidism. Okay, so I hope you have understood these particular points, guys. Okay. Got it? Right. Now, thyroglossal cyst. What is this particular thyroglossal cyst? This is basically your congenital anomaly. What is this congenital anomaly? So what happens is that during the embryological period, from this particular tongue, the thyroglossal duct basically comes down. It comes down to the neck. It basically leads to the formation of a thyroid gland. After the thyroid gland is formed, this particular thyroglossal duct should kind of disappear. But if at all this particular thyroglossal duct it fails to disappear, the persistence of this particular thyroglossal duct is basically called as what you call as a thyroglossal cyst. Clinical features is nothing. It is just a what you call as a midline swelling. So what you basically have is a midline swelling. And what you need to understand about this particular midline swelling is that it is going to move with the deglutination and is going to move with what you call as a protrusion of the tongue. Okay, so it is going to move with the deglutination and the protrusion of the tongue. Okay, right. Now what about the diagnosis over here? So diagnosis is basically obviously the clinical, then you can use an ultrasound or you can use whatever the FNAC and everything. And yes, some of you guys have pointed it out. The most common location of this particular thyroglossal cyst is subhyoid, just below the hyoid bone. That is what is going to be the most common site of this particular kind of thyroglossal cyst. What about the management? So the treatment of this particular patient is what you call as a cyst trunk operation. Okay, so cyst trunk operation or cyst trunk surgery, that is what is going to be the management of these particular patients. Why so? And why do you want to operate on these particular patients? It is just a simple swelling which is present in the midline, right? It's not harming the patient. So why on earth do you want to kind of operate on these particular patients? Because it can lead to an infection which can ultimately lead to the fistula. Yes, absolutely important. Another important risk factor is it can lead to something which is called as a papillary carcinoma of thyroid. So it is also a risk factor for your papillary carcinoma of thyroid. Over a period of time, it can also lead to a papillary carcinoma of thyroid, and that is the reason why you have to kind of operate. What you do in the cyst trunk operation, you remove the entire duct, you remove the central portion of the hyoid bone, you remove the base of the tongue, and obviously you remove the cyst. Okay, so that's what you need to understand over here. Okay, what about the thyroglossal fistula? It is always an acquired condition. It is never a congenital condition. It is always an acquired. So what happens is the infection happens and it might kind of burst open, or infection happens and somebody kind of did an incision and drainage, and that leads to the kind of thyroglossal fistula formation. So that is what you need to understand over here. What about the investigations of the thyroid? So you have a number of investigations. The first investigation, this was asked once, so it is always a thyroid function test. So anybody who is walking to us with a thyroid problem, the first investigation which we order is T3, T4, TSH to see whether the patient is euthyroid, hypothyroid, hypothyroid. That is the first thing which you offer. Then we have an ultrasound, which is basically to see whether it is a cystic lesion or the solid lesion or something like that. FNAC, that is the gold, like what you can say is you basically gives you the diagnosis of a solitary thyroid nodule. So whenever there's a nodule which is present in the any particular individual, in order to diagnose what that particular nodule is, always an FNAC is kind of done in these particular patients. Now thyroid scan is something which is important. We are going to talk about that particular thing in detail. Then we have a CT scan and we have a biopsy. So what about the thyroid scan? So what is your understanding about the thyroid scan? Okay, so if I simply ask you, please put just say that my statement is true or false. I tell you that thyroid scan can tell you whether you are dealing with a malignant lesion or a benign lesion. I'll repeat myself. Thyroid scan can tell you whether you are dealing with a malignant lesion or a benign kind of a lesion. Okay, so yeah, whether this particular statement is true or false, can you please tell me? Okay, so if at all you're saying that this particular statement is true, that's not kind of right. Okay, so what you need, yes, absolute good. So thyroid scan basically tells us that, you know what, whether that particular nodule is basically taking up good amount of thyroid like iodine or not. Okay, so it basically tells us about the functionality of the kind of a nodule. Okay, so how do you perform it? That's fine. You basically give the patients a radioactive iodine. So what is this particular radioactive iodine? So the two things which you have to kind of remember over here is iodine 131 and iodine 123. Okay, so what is the T half of this particular iodine 131? The T half of the iodine 131 is 8 days and for 123 is 13 hours. Okay, so that is why this iodine 123 is basically used for what you refer to as your diagnostic purposes, and iodine 131 is basically used for diagnostic as well as therapeutic purposes. The therapeutic activity of the iodine 131 is because of the emission of the beta radiations. Okay, because of the beta rays, what you basically have is the therapeutic activity of the iodine 131. Now what do you use? I told you. What does it tell you? Okay, it doesn't tell you whether you are dealing with a malignant or a benign lesion. It basically tells us whether that particular nodule is having an increased activity or whether it is having a reduced activity. That is what this basically tells you, right? So can you please tell me what is this? Okay, forget about this. Can you please tell me what is this? Is it like a hot nodule or a cold nodule? Can you please tell me this? Okay, so please try to understand. This is what is a hot nodule. Okay, what is this? This is what is a hot nodule. Okay, and what is this? This is what is a cold nodule. Okay, so this is what is a cold nodule. Many students, I should have asked you this. Many students basically say that, sir, this is a hot nodule. No, this is not a hot nodule, guys. So what do I tell them is that whenever you get an image like this in your mind, obviously you cannot draw in the exam. So in your mind, just try to complete the image of a thyroid. Now, once you complete the image of a thyroid, now you get to know that, you know what, this is basically a part of a thyroid which is having an uptake which is less as compared to the rest of a thyroid tissue. So what is this? This is what is a cold nodule. So what is a cold nodule? Essentially, cold nodule is basically a kind of a nodule which is basically having an uptake of a radioactive iodine which is less as compared to the rest of a thyroid tissue. On the other hand, a hot nodule, again, they'll do the similar kind of a thing. Try to complete this particular thyroid gland. Over here, you're still able to see a bit of a thyroid tissue. In exams, sometimes all you basically get is this. Okay, all you basically get is this. There's nothing around that. Okay, then the students get confused. So always try to complete the kind of a thyroid thing, and now you easily can tell that, you know what, this particular part of a thyroid is having more uptake as compared to the rest of a thyroid gland. So this is what is a hot nodule. Okay, so this is what is a hot nodule. Okay, so I hope you are able to kind of understand these particular thing, right? Okay, right. So again, Satyaja, as you're saying that cold nodule will have reduced uptake due to malignancy. So does this imply that in the hot nodule the malignancy will not occur? No, it doesn't imply that. Are you understanding my point? So again, coming back to my point, it basically tells you about the uptake. So yes, no doubt in the cold nodule, the risk of malignancy is a bit more. It is around 15%, 10 to 15%. In the hot nodule, it is basically around what you call as a 5%. But yeah, I hope you have understood this particular point, guys. Okay, so the risk of malignancy is more in the cold nodule as compared to that of the hot nodule. But what you need to understand is that it doesn't tell you whether the malignancy is present or not or something like that. Okay, yeah. I hope you have understood this particular point, guys. Yeah, right? Okay. Now, multiple hot basically can occur in the multinodular goiter. If at all you have a multinodular goiter, then you can have this particular multiple hot nodules. Okay, right. Now let's talk about the malignancies of a thyroid. So the first thing which we're going to talk about is the papillary carcinoma of thyroid. Now this is a very, very important thing, and I'm pretty sure that you guys must be aware of it. So I'll quickly cover it. So this is what is the most common kind of a thyroid malignancy, and this is also the thyroid malignancy which is having the best prognosis, the most common and the one which is having the best prognosis. It is multifocal, non-encapsulated. Forget about this. Just remember that it has a genetic mutation. BRAF gene mutation is something which is basically present in the kind of papillary calcium thyroid. Presentation of that, it is going to be a lateral aberrant thyroid nodule, or it can have a, so it basically has an early lymphatic metastasis. Okay, what is had is an early lymphatic mets. Okay, so there is a chance that inside the thyroid, what you can have is you can have an occult thyroid nodule. It means that when you palpate the thyroid, you're not able to find any particular nodule over here, but you are able to find that there is a kind of a enlargement on the neck. Okay, so are you able to understand this particular point, right? So that is what you need to understand over here. Okay, early lymphatic metastasis is a characteristic feature of your papillary carcinothyroid. What is the risk factor? Radiation exposure. So this is basically more common in the young females, around 30-35 years. Females, this is kind of more common. So what would you understand by the radiation exposure? Probably in the childhood, because of some or the other reason, the patients would have received the radiation to the neck, and now the patients are basically coming to you with a papillary carcinoma of thyroid. Okay, another important risk factor which we just talked to you about is a thyroglossal cyst. Okay, so long-standing thyroglossal cyst can be a risk factor for what you call as a papillary carcinoma of thyroid. So presentation, I told you, lateral aberrant thyroid nodule and everything. Diagnosis and FNAC, what do you see in the FNAC? Yes, as she has already told us. So orphan NEI nucleus, and what you can have is a pseudo grooving. Okay, so Samoma body. So three things. Okay, Samoma bodies. I'm pretty sure that at least 100 people would have taught you this. Samoma bodies. So where are these particular Samoma bodies present? Papillary carcinoma of thyroid, papillary carcinoma of kidney, then we have a meningioma and the serous cystadenoma of the ovary. Okay, so these are the places where you basically find the Samoma bodies. Then you have an orphan NEI nuclei, and then you have a pseudo grooving. Forget about this particular pseudo grooving. Just remember orphan NEI nuclei and the Samoma bodies. Okay, so these are the places where you this is what you basically find out the FNAC. So metastasis, as I told you, early lymphatic metastasis. So usually what it's kind of famous for is a lymphatic metastasis. So lymphatic metastasis can basically occur in this. What about the treatment? So treatment is total thyroidectomy plus minus modified radical neck dissection. So Satyaja is asking, Hashimoto's will also lead to papillary. Yes, you're right. So Hashimoto's thyroiditis can also lead to papillary, but please try to understand. If I ask you that Hashimoto's thyroiditis, if I give you a question, Hashimoto's thyroiditis is a risk factor for what you call as thyroid lymphoma and the papillary carcinoma of thyroid. Both are in the option. What are you going to choose? So please try to understand Hashimoto's thyroiditis is a much more important risk factor for the thyroid lymphoma. I deliberately did not tell you because I didn't want to kind of confuse you over here. It is kind of written in the Sebastian that Hashimoto's thyroiditis can lead to papillary carcinoma of thyroid, but the incidence is very, very less. Okay, so please try to understand that. It is a much more important risk factor for the thyroid lymphoma. Okay, right? So yeah, the management is total thyroidectomy plus minus modified radical neck dissection. Radioactive iodine you can basically use in order to look for any particular residual disease or for kind of detecting the metastasis, and it can also be used in order to taking care of the residual disease, because as we know that the iodine 131 can also be therapeutic. Okay, so forget about this. Just remember the radioactive iodine has a role to play in the differentiated thyroid malignancies like your papillary and the follicular carcinoma thyroid. These are the prognostic kind of scoring system. You have edges, MS, masses. Just remember the best one out of this is the messes. You can just go through this, but this messes is the one which is the kind of a most reliable staging method available over here. Okay, then we have a follicular carcinoma of thyroid. In the follicular carcinoma of thyroid, what you need to understand, this is the second most common thyroid malignancy. That's fine, nothing major about this. Presentation is again a thyroid nodule and something like that. Genetic mutations, n number of genetic mutations can occur. Just remember at least PTE and gene mutations. So there are various other genetic mutations which are associated with this. Okay, now risk factor is something which is important. So what is the risk factor for this? A long-standing colloid goiter. Okay, a long-standing colloid goiter. Okay, I hope you've understood this particular point. The risk factor for this particular stuff is a long-standing colloid goiter. Long-standing colloid goiter is a risk factor for this follicular carcinoma thyroid. Metastasis, here what you need to understand is the hematogenous metastasis. Hematogenous metastasis is something which is more common as compared to that lymphatic metastasis. Okay, hematogenous metastasis is a kind of more common. And here what you basically get is the osteolytic metastasis. Okay, so bony metastasis or osteolytic metastasis. That is what you need to understand. FNAC. Okay, so what you need to understand is FNAC, it cannot distinguish. Okay, it cannot distinguish between what you call as an follicular adenoma and carcinoma. Are you understand my point? So FNAC, it cannot distinguish between the follicular adenoma and the carcinoma. This is what you need to understand over here. So for this, what you basically need is a biopsy. So what you basically essentially do is that if at all, what you need to understand is, what you basically understand over here is that when you basically do an FNAC, and if at all it basically shows a follicular lesion, then what essentially you have to kind of do is you have to kind of remove that particular nodule. Like you need to do an like hemithyroidectomy, and you have to send it for the histopathological examination. And once the histopathological examination comes back, and if it all shows that you are dealing with a follicular carcinoma thyroid, then you have to perform a completion thyroidectomy. Okay, right? Okay, right. Now, yes, so osteolytic or the osteosclerotic is something which you basically kind of see in the prostate carcinoma as well. Yes, you're right, Satya. Okay, now what about the treatment? Treatment is again the same, total thyroidectomy plus minus modified radical neck dissection. That is what you have to kind of perform over there. Okay, now what about this, guys? Medullary carcinoma thyroid. In the medullary carcinoma thyroid, what you need to understand is what is the cause of that. Okay, so here what is happening, that is a tumor which is basically arising from the parafollicular C cells. Okay, parafollicular C cells. Okay, so in the medullary carcinoma thyroid, what is basically happening is that there's a tumor which is basically arising from the parafollicular C cells. Okay, so that is what is the cause of that. Now the syndrome, this is basically associated with the MEN syndrome. Okay, so this is one which is basically associated with the MEN syndrome. Okay, MEN, which one or two? So this is the one which is basically associated with the MEN2A and MEN2B syndrome. Okay, so this is the one which is associated with the MEN2A and MEN2B syndrome. Okay, now this is what kind of leads to a familial syndrome. Okay, so MEN2A, MEN2B, these are the familial syndromes which are associated with this particular medullary carcinoma thyroid. So that is what you need to understand. The clinical features are obviously it's going to be so the most common presentation is basically diarrhea. The most common presentation is your diarrhea. Okay, so this is basically because of the serotonin and everything. The patients can also land up into hypocalcemia. Okay, calcium levels can basically go down because these parafollicular C cells, what they do, they basically secrete calcitonin. And what is the role of the calcitonin? The role of the calcitonin is that they are basically there to bring the calcium levels down. Okay, so they are basically there to kind of bring the calcium levels down. Okay, so because of this, the patients may have a hypocalcemia. So this is what you need to understand is by. Okay, now okay, now labs and the FNAC or something like that. Okay, so right, so on the FNAC, what you're going to find over here, you're basically going to find an amyloid stroma. Okay, amyloid stroma. So if at all the question basically says that, you know what, there's a patient who are basically having an amyloid stroma, if on the FNAC, they are basically talking about the medullary carcinoma thyroid. So please do remember that. This is very, very important. Okay, right? Now, metastasis. So please try to understand over here. Here, both the lymphatic and the hematogenous both can occur. Hematogenous both can occur. Hematogenous can basically go to the bones, and the bones here what you basically get is a osteoblastic metastasis. Okay, so here what you basically get is a blastic metastasis. Okay, now the hematogenous metastasis can also occur to the liver. Okay, on the liver, that is what is a systemic metastasis. So systemic metastasis basically happens to the liver. That is what you need to understand. And the lymphatic, yeah, obviously that is kind of which is kind of there. So medullary carcinoma thyroid is a bit more aggressive kind of a tumor. What about the management here? So in the follicular and the papillary, what did we say? That we do a total thyroidectomy plus minus modified radical neck dissection. Okay, what we do is we do a plus minus modified radical neck dissection. Over here, what you need to understand is in the treatment over here what is there? Here we have what you call as a like obviously we do a total thyroidectomy, and here what we basically do is a mandatory central node dissection. Okay, so what you basically do is you do a mandatory central node dissection. Okay, so here what you basically do is a mandatory central node dissection. That is what you need to understand over here. Okay, so osteoblastic would also occur in the RCC, sir. Okay, I'll come back to you. So Satya, just give me a minute. Okay, right. So this is what you need to understand. We have mandatory central node dissection. What is the central node? That is a lymph node station 6. So if you kind of remove that, and if at all that is a tumor, then you basically go ahead and perform a modified radical neck dissection as well. Role of the radioactive iodine, there is no role. Please try to understand there is a no role of radioactive iodine because this is not arising from the thyroid follicle. This is basically arising from the parafollicular C cells. Okay, now coming back to your question, Satya, osteoblastic metastasis are seen in the RCC also. So please try to understand in the RCC, predominantly what you basically see is a visceral metastasis. Okay, predominantly what you basically see is a visceral metastasis. So that is what you need to understand over here. Okay, right. So like the bony metastasis are not that kind of a common, but here what you basically see is an kind of a osteolytic metastasis, basically in the kind of ribs. Okay, so primarily basically that basically happens over there. Okay, right. Now anaplastic carcinoma of thyroid, what you need to understand over here is, so in the RCC you should remember that cannonball metastasis. So you would have read about that cannonball metastasis occurring to the lungs. That X-ray is also very, very important. That is something which you need to, and recently in the AIMS they had shown you that image as well, right? So it is predominantly a hematogenous metastasis to the lungs, cannonball metastasis. Bony metastases are a bit rare in this. Okay, so that's what you need to understand. Okay, right. Now anaplastic carcinoma of the thyroid, what you need to understand over here, this is the one which is basically having the worst prognosis. Okay, the worst prognosis is basically of the anaplastic carcinoma of thyroid. This is the most malignant. What is the characteristic feature of this? That it basically leads to what you call as a compressive symptoms. Okay, it leads to a compressive symptoms. Compressive symptoms. So what you need to understand is that the trachea and the esophagus and everything, that is what is kind of getting yeah, so trachea is kind of getting compressed, esophagus is getting compressed. Because of this, the patients are going to have a respiratory distress and the dysphagia and all those particular things. That is what is going to be the presentation of the anaplastic carcinoma of thyroid. Now, the important thing which you need to understand over here is a differential diagnosis. So, in anaplastic carcinoma of thyroid, the important differential diagnosis is something which is called as your Riedel's thyroiditis. Okay, so Riedel's thyroiditis, this is what is an important differential diagnosis of this. And in order to distinguish the Riedel's thyroiditis from the anaplastic carcinoma of thyroid, what you basically have to perform is a biopsy. So this is one of the indications of your biopsy. What about the management? So it is basically palliative management. Okay, so here the management is predominantly palliative. Okay, so please try to understand here what we have is a predominantly palliative management. Okay, wooden box chest like thing. Okay, so yeah, so this is what is called as a woody thyroid. Okay, so this basically what you need to understand is that because of the intense fibrosis, what happens is that the thyroid becomes like a wood-like. Okay, and even if you do an FNAC, many times you're not able to kind of diagnose this. This is what you need to understand. Fibrosis in the Riedel's, yes. So what you need to understand, this basically happens in both. That's why they are the differential diagnosis of each other. These are the locally invasive, and there is a lot of fibrosis which is associated with this. Okay, so I hope you have understood. That is why they are such a important differential diagnosis. One is the most lethal, and like it's a very, very malignant kind of malignancy of a thyroid, and the other one is a benign condition which will get recovered after, let's say, 6 months, 7 months, or something like that. Okay, fibrosis is a feature of both. Now, thyroid lymphoma. What type of a thyroid lymphoma occurs over here? So is it like a B cell or a T cell? So please try to understand, it is a diffuse large B cell lymphoma. B cell lymphoma. What you basically get over here is a diffuse large B cell lymphoma. What is the risk factor? We just talked about Hashimoto's thyroiditis. What about the diagnosis? Again, over here is a biopsy. FNAC, we don't just rely on the FNAC, we have to go ahead with the biopsy because of the treatment. It is a medical management. Okay, it is a medical management. You don't go ahead and kind of do the surgery. Every time you have a lymphoma in your body, do you go ahead and do a surgery? No, right? You give the patients chemotherapy. So you basically give the patients CHOP regimen. So over here also, the medical management is basically chemotherapy. So you predominantly give the patients chemotherapy, the CHOP regimen. If at all there is some kind of a residual kind of lesion, then you have to kind of go ahead and do a surgery or something like that. Okay, so I hope you have understood this particular point. So thyroid lymphoma, what you basically do is a medical management, chemotherapy, CHOP therapy. If at all there is some kind of a residual lesion, then you basically go ahead and do a surgery. Okay, let's not go over here. Okay, so what you need to understand in the complications of a thyroidectomy. Okay, so what you need to understand about the complications of the thyroidectomy is that hemorrhage. Okay, so here the important thing which you need to understand or remember is something which is called as a tension hematoma. What is this particular tension hematoma? Tension hematoma is basically a kind of a condition where there is a reactionary hemorrhage. Okay, so this is what is a reactionary hemorrhage. So here what is happening is that because of the slippage of the ligature, so let's assume that there is a thyroid artery, you have tied a ligature over that. If at all that particular ligature gets slipped off, then what's going to happen? there's going to be the blood which is going to get accumulated in this particular thyroid, like this particular neck region. And because the skin sutures have been taken, so what is going to happen, the blood will not find its way to kind of come out. So because of this, what is going to happen, the blood will get accumulated in the neck, and that is what is going to kind of compress the underlying trachea and the esophagus and everything. And because of this, what you need to understand is the patients are going to have a respiratory distress. So the management of the tension hematoma is that you have to kind of immediately open this particular suture line and evacuate that particular clot. And yes, this is what is usually going to happen before 24 hours. Okay. Yes, 24 hours, within 24 hours. After 24 hours, usually it is because of the infection. Okay, so I hope you've understood this particular point. So yeah, this is what is called as a tension hematoma, which is going to occur within 24 hours. That is what is a reactionary hemorrhage. This is basically happening because of the slippage of the ligature. Okay, now, okay, so nerve damage. If we talk about the nerve damage, what is the most common nerve which is kind of injured in the thyroidectomy? Can you please help me with this? Very, very important. Recurrent laryngeal nerve or the external laryngeal nerve, which is the most common nerve injured in the thyroidectomy? The answer over here is in external laryngeal nerve. This is much more common than the recurrent laryngeal nerve. Okay, so recurrent laryngeal nerve might sound a bit more attractive, but please try to understand external laryngeal nerve is the most commonly injured nerve in this. Okay, and what about the bilateral, like the respiratory distress? So please remember, the respiratory distress can occur after the bilateral recurrent laryngeal nerve palsy. If at all both of the recurrent laryngeal nerves are cut, only then what you need to understand is that you're going to have something which is called as a respiratory distress. If at all the unilateral recurrent laryngeal nerve is cut, then what you're going to have, now you're going to have a hoarseness of the voice. In the bilateral recurrent laryngeal nerve palsy, you're basically going to have a respiratory distress. Okay, so I hope you have understood this particular point, guys. Okay, now Graves' disease. Okay, let's kind of, okay, so what is a Graves' disease? Graves' disease is basically what you call as a autoimmune disease. So here what is going to happen, that there is going to be the antibodies which are going to get formed against the thyroid follicles, and these particular antibodies are going to be a thyroid stimulating antibody. So these particular antibodies are thyroid stimulating antibodies. Okay, what are these? These thyroid stimulating antibodies. So what's going to happen, they're basically going to go and get attached to the thyroid follicles, and they're going to increase the production of a thyroid hormone. So that is why the Graves' disease is the most common cause of your hyperthyroidism. Okay, it is the most common cause of your hyperthyroidism. Understood? Now, what is the difference between the other hyperthyroidism and the Graves' disease? Eye signs. Okay, so here what is going to happen, you also get an ophthalmopathy. So here you get all these particular signs: Stellwag sign, infrequent blinking sign, lid lag sign, von Graffi sign, Mobius sign, Joffroy sign, all these particular signs which you have very well read in your ophthalmology also. So you get all these particular signs. These are the eye signs which you basically get in this particular Graves' disease. The treatment. Okay, so I hope you have understood. There's a difference between hyperthyroidism and the Graves' disease. What is the difference? In the hyperthyroidism, all you basically get is increased BMR, heart rate increased, and all those particular stuff. Over here, what you're basically going to get is, you're going to get all the features of hyperthyroidism, but along with that, you're also going to get an ophthalmopathy. Along with that, you're also going to get something which is called as a dermopathy, right? So all these particular things you basically get. What about the management? So the first thing is, yes, you're going to start the patients on the beta blockers, because this is what is going to give you the symptomatic relief. Okay, symptomatic relief. Okay, this is what is going to give you a symptomatic relief. Okay, then what are the other options which are available to you? Please try to understand. This is something which you're going to do in every patient. You're going to start the patients on the beta blocker. So if at all they tell you that you have a patient with a Graves' disease, what are you going to do? How you're going to start the management? First thing which you basically do is start the patients on the beta blockers. Then you have anti-thyroid medications, you have radioactive iodine, you have a surgery. So these are the three things which you have. Anti-thyroid medications are the carbimazole, methimazole, all those particular stuff. The important side effect is agranulocytosis. I'm pretty sure that you would have read this in pharmacology in a great depth. So yeah, important problem is the agranulocytosis. Okay, then we have radioactive iodine. Radioactive iodine is basically preferred in what you call as an old debilitated patients, old comorbid patients who have a lot of comorbidity. In these particular patients, you kind of prefer. Where is it contraindicated, radioactive iodine? So please tell me where it is contraindicated. First is the pregnancy. Okay, obviously you are not going to give this. Then in the children, because their growth might get affected. And then what else? You are also going to kind of avoid this if at all the predominant symptom is ophthalmopathy. Because whenever you give this particular radioactive iodine, they're basically going to kind of in the ophthalmopathy, what you need to understand is, because of the extraocular muscles, there is an in the extraocular muscles, there is a deposition of an extracellular matrix. Because of this, what is happening? These extraocular muscles are becoming bulky, and because of this, already the pressure on the eyeball is a bit high. Now what you need to understand is, if at all you give this particular radioactive iodine, what is going to happen? It is going to further increase the pressure inside the eyeball, which obviously you don't want, right? So that is why it is contraindicated if at all the predominant features of these particular patients is ophthalmopathy. What about the surgery? So yes, surgery can be done, but you cannot just straight away go and operate on these particular patients. You have to kind of convert the patients into euthyroid state first. Okay, so you have to kind of convert the patients into the euthyroid state. How do you kind of do that? You start the patients on what you call as an anti-thyroid medications. You give that for around 4 to 6 weeks. Then you also give the patients Lugol's iodine. What is this particular Lugol's iodine? Lugol's iodine is basically what you call as a like liquid iodine, which is very, very high concentration of iodine. Now you would say that, you know what, iodine, which is whenever we have a goiter or something like that, we say that let's have a iodized kind of a salt. That is because of lack of iodine or something like that, right? But here we are giving the iodine to this particular patient. So this is because of the Wolff-Chekhov effect, right? Are you understanding my point? So yeah, Wolff-Chekhov effect. Okay, so yes, Satyaja, you're right. Thyroid storm related to the Lugol's iodine. No, so Lugol's iodine is basically used in the treatment or the management of the thyroid storm. Now you have understood the reason why, right? Because this will lead to iodine-induced hypothyroidism. When you give such a high dose of iodine, it basically reduces the release of a thyroid hormone. That is what is the Wolff-Chekhov effect of Wolff. Yeah, you understand my point? So yeah, and yes, absolutely right. Lugol's iodine also basically reduces the vascularity of a thyroid gland, so it becomes easier for you to kind of operate on these particular patients. So the Lugol's iodine is basically started 8 to 10 days before the surgery, and the anti-thyroid medications are basically started 4 to 6 weeks prior in order to make these particular patients euthyroid. Okay, so I hope you have understood this particular point. Hashimoto's thyroiditis, it is again an autoimmune disease, but here rather like in the Graves' disease, what happened was that when you give those particular antibodies were lasts, that is long-acting thyroid stimulating antibodies. But here these particular antibodies are thyroid destroying antibodies. They basically destroy the thyroid tissue. Okay, now what is the another name of this particular Hashimoto's thyroiditis? It is also called as a stroma lymphomatosum. What is this particular stroma lymphomatosum? But basically tells that inside the thyroid gland, it is not just the antibodies, but also the what you call as a lymphocytes, which are basically attacking on these particular thyroid tissue. I hope you are able to understand the point. This is what is called as the stroma lymphomatosum. So autoimmune disease, antibodies destroy the thyroid, all those particular things are fine. That's all okay. Now, then we have, this is more common in the females, blah, blah, blah. What is the cause of this particular Hashimoto's thyroiditis? So what is the cause of this particular Hashimoto's thyroiditis? As I told you, it is an autoimmune disease. That's fine. So what is an antibody which is kind of present over here? So we have anti-topoisomerase. Topoisomerase antibody. Okay, anti-topoisomerase. Okay, so anti-thyroglobulin, anti-topoisomerase, anti-TPO, anti-topoisomerase. But this is the more common one. Anti-topoisomerase, this is what is the more common one. What about the presentation? So as I told you, this is going to present to you with hypothyroidism. So this is the most common cause of your hypothyroidism. Okay, so I hope you have understood this particular point, guys. Okay, right, thyroid storm, inadequate handling. Okay, so yes, thyroid storm is basically going to happen if at all you have kind of unprepared. Okay, so if at all the patients are not prepared, in other words, the patients have not yet become euthyroid and you have operated on these particular patients, or the patient had some kind of an infection or some kind of a stress or something like that in hypothyroidism state, then the patients may land up into thyroid storm. Okay, I hope you're able to understand this particular point, guys. Okay, got it. Now the diagnosis is basically based on the FNAC. What you're going to find on an FNAC? So you're going to find in Hurtle cells. So what are these Hurtle cells? Hurtle cells are nothing but a Ashkenazi cells, Ashkenazi or Hurtle cells, and then you're also going to find the lymphocytes. Now, what is the risk factor with this Hashimoto's thyroiditis? We have already discussed that the risk factor with these particular Hashimoto's thyroiditis is what you call as thyroid lymphoma, right? And it can also, like very few portions of that, a few patients might also lead to papillary carcinoma. But the important risk factor for this is like important complication of the Hashimoto's thyroiditis is thyroid lymphoma. So what is the treatment? The treatment is because it is going to lead to a prolonged hypothyroidism. Okay, prolonged hypothyroidism, and that is why the treatment is thyroid replacement. Okay, so you have to kind of give the thyroid hormone. Okay, so yeah, basically patients, so many patients, like few patients after the pregnancy, they basically landed with Hashimoto's thyroiditis. They are basically rendered hypothyroid, and they have to kind of take the thyroid hormone for their entire life. Okay, so that is what you need to understand over here. Lifelong levothyroxine. Yes, absolutely right. Now, sir, any antibodies in the Graves' disease? I told you, like last, right? Long-acting thyroid-stimulating antibodies. It's not any other name. So last is basically the thing, long-acting thyroid-stimulating antibody. Okay, right. Now, lastly, let's talk about this particular. These are all the names of the same disease, that is subacute thyroiditis, viral thyroiditis, giant cell thyroiditis, granulomatous thyroiditis, Deak-Verwin thyroiditis. All these are the names of the same kind of thing. Now, what is happening over here, that you have a young female. Okay, so usually in the questions also they are going to give you, usually they give around 40-45 years. Females is going to be kind of there. There's going to be the patient who is having an upper respiratory tract infection, and after that 4 weeks later, okay, after 4 weeks, the patients are basically going to have a painful thyroid swelling. Thyroid swelling. So what happens over here was that because of this particular upper respiratory tract infection, which was caused because of the viral infection. So just give me a minute. So that upper respiratory tract infection was caused by because of the viral infection, and because of that, what happens that there is a granulomatous reaction, and that basically leads to the destruction of the thyroid gland, which leads to the patients turning into the hypothyroid. But this is a self-limiting condition. So over a period of time, the thyroid hormones are going to regenerate, and because of this, so patients are going to come back to the normal. Irrespective, like in the Hashimoto's thyroiditis, there was a prolonged hypothyroidism, but over here, over a period of time, the recovery is going to happen, and the patients are basically going to come back to the normal. Okay, so I hope you're able to understand this point. What is this? So all these are the names of the same disease. I'll explain it to you. Okay, subacute thyroiditis, why? Because it is taking 4 weeks for the patients to kind of land up into this. Viral thyroiditis, because viral infection was there. Giant cell thyroiditis, why? Because if you do an FNAC, what you basically find is a giant cells. Granulomatous thyroiditis, because granulomatous reaction is taking place. Deak-Verwin thyroiditis is basically what is the kind of scientist or whatever the doctor who basically kind of gave you this. And then there is also called as a silent thyroiditis. What do you understand by that? This is another, also the name of this only, silent thyroiditis. Why is it called as a silent thyroiditis? It's not like that it's not painful. It's a painful condition, okay? And why it is called as a silent thyroiditis? Because if you do a radioactive iodine study in these particular patients, it is going to have no uptake. And that is the reason why this is also referred to as your silent thyroiditis, okay? Now, another important thing is in the labs. In the labs, what you're going to find is, you're going to find a raised ESR, okay? So in the labs, what you're going to find is a raised ESR, okay? Raised ESR, that is a characteristic kind of a thing over here. What about the management? Because it is a self-limiting condition, but the patients are in pain, right? So you have to give the patients painkillers and the steroids. So this can be kind of given to these particular patients, okay? So I hope you have understood this point. Very, very important topic, okay? Subacute thyroiditis, nothing to remember, nothing to mug up, but all these particular names have significance. If you just remember all these particular names, you will remember the like this particular viral or whatever the subacute thyroiditis, okay? Then Riedl's thyroiditis. What is this particular Riedl's thyroiditis in this? Okay, what did I tell you about this? That here there's again locally invasive disease. There's a lot of fibrosis which is basically taking place, and because of this, what is the patients are going to have? Compressive symptoms, dysphagia, respiratory distress, all these particular things are going to happen over here. The important differential diagnosis is here anaplastic carcinoma thyroid, that is why biopsy is needed. The difference is the Riedl's thyroiditis is a self-limiting condition, and you basically give the patients some selective estrogen receptor modulators and the steroids in order for that to kind of get treated, right? But the anaplastic carcinoma thyroid, that is what is a very, very poor prognosis, and you have to give a palliative therapy to those particular patients, okay? Right? Now, lastly, what about the retrosternal goiter? What about this particular retrosternal goiter? If at all, more than 50% of a thyroid tissue is basically present inside the mediastinum, that is what is referred to as your retrosternal goiter. Now, the retrosternal goiter can be either primary or it can be secondary. What do you understand by the primary? Primary basically means that it started a development inside the thoracic cavity itself. What about the secondary? Secondary basically means it started a development in the neck and then it basically went to lie inside the thoracic cavity. Now it's a logical thing to understand that if at all there is a primary retrosternal goiter, the blood supply is basically going to from the mediastinal vessels. Okay, So obviously, if at all it's starting a development inside the thoracic cavity only, the mediastinal vessels are going to are going to supply it. But if at all it's a secondary retrosternal goiter that had started the development in the neck, and then it basically goes down, the blood supply is going to be from the cervical vessels. Are you understand my point? So here, the predominantly it is basically from the cervical vessels. Okay. Now, what they asked is that what is the preferred route of surgery over here? So once they had asked you this, and they did not give you whether you are dealing with the primary or the secondary retrosternal goiter. If they just simply tell you that, you know what is the preferred route of the management of these particular patients, this is what is going to be your like cervical incision has to be given. Why? Because the secondary retrosternal goiter is much more common as compared to the primary. Around 95% of all the retrosternal goiters are the secondary retrosternal goiter over here. Okay, so I hope you have understood this particular point. Around 95% are the secondary. But if they change the question, and if at all they ask you what is the preferred method of surgery for the primary retrosternal goiter, then you'll have to say that it's a thoracotomy. I hope you have understood this particular point. The question which they had asked you, they did not mention primary or secondary, but secondary is much more common, and that is why you give a cervical incision over here. Okay, I hope you have understood this particular point. Now lastly, what you have is but yes, you have to understand, if they specifically ask you about the primary, then yes, you have to kind of go with the retrosternal, like a thoracotomy. Now, is it like never in the secondary retrosternal goiter thoracotomy is needed? No, it's not like that. If at all the retrosternal goiter has become very big, it can always take a parasitic vessels from the thoracic kind of wall, right? And that is the importance of doing a pre-operative contrast enhanced CT scan. That is what is going to give you a good idea about the blood supply of that particular goiter, and then you will be able to understand that whether the thoracotomy will be needed or not. It's not a joke, right? Inside the surgery, you cannot just tell the anesthetist that, you know what, I want to do a thoracotomy. You cannot do that, right? It needs planning. This anesthetists have to kind of plan things, and they have to kind of put a double lumen kind of endotracheal tube and everything. So you have to kind of plan it preoperatively, and that is the importance of doing a contrast enhanced CT scan in the preoperative period in the secondary retrosternal, like in the retrosternal goiter. Okay, what about the clinical features? So yes, because of this particular goiter, there's going to be the compression on the trachea and the esophagus and everything. So patients will have dysphagia, dyspnea, all those particular things are going to happen. And as I told you, that is the role of the contrast enhanced CT scan. Lastly, there's something which is called as the Pemberton sign. So Pemberton sign is basically a provocative kind of a test. So when the patient walks to you in the clinic, the patient's absolutely fine. But when you kind of ask the patients to kind of lift both the arms above the ears or something like that, this particular area becomes kind of narrow, and the patient basically develops facial plethora. So I do not have the image of that, but yeah, that is what is basically referred to as your Pemberton sign, facial plethora development in these particular patients. Okay, right? So that is all about the thyroid, guys, which I wish to talk to you about. Now, we have already kind of talked for around 2 or 15 minutes or something like that. I thought that everything will get completed by 12, but clearly it will not get completed. So what I'll do is, whatever we have completed, I will kind of stop over here right now. Tomorrow again we'll meet. Okay, tomorrow again we'll meet, probably at around, let's say, 9 only we'll meet. Okay, 9 to 11, 11:30 we'll do another session, so part 2, and then part 3 also we'll do probably day after tomorrow, or maybe on, like, I'll let you know. I'll let you know tomorrow. Okay, now I hope you kind of gained something out of this particular session, guys. Now, if you kind of gained something out of this particular kind of session, I would request you, I will need a favor from you. Like, okay, so please help me kind of reach to more people over here, and if at all you can share this particular stuff with your juniors or whatever, your friends or something like that, it will be very helpful for me. And at the same time, if at all you have not yet joined, you can consider joining my, this is my number, you can just scan this so that you can kind of reach out to me. Just drop me a text message. I will kind of add you to one of the groups, WhatsApp group. Shortly I'll be starting a Telegram group as well. So yeah, like, you can just drop your text and I'll add you to the WhatsApp or the Telegram group. Not yet started, but yeah, like, the WhatsApp group is still there, it's active. There I share a couple of MCQs, I share a couple of explanations and everything, so you can consider joining that. This is what is a YouTube channel. If you have not joined, you can please subscribe to it. That will be very beneficial for me. And you can consider following me on the Instagram. If you do that too, I'll be kind of sharing a couple of kind of MCQs in the form of reels or something like that. In a couple of days, I'll be starting that. Okay, right. Will tomorrow class be there? Yes, tomorrow class will be there from around 9 to 11. The tomorrow class will be there, 11, 11:30, whatever. Okay, right, guys. Thank you so much. And yeah, thank you. Right, please early. Then by let's keep it from 9 to 11 now. 11 your it kind of gets closed. Okay, right, 9 to 11 we'll keep it. Yeah, I'll do that. So I've actually mailed them, so their link, like, it Basically it takes around 1 to 2 days to get the permission to kind of activate the link or something like that. I have put that into the procedure. Over a period of time, I'll put the link of the WhatsApp group in the description box as well. So yes, I mean, for the students who will be watching it later, so what you will find, like by the time you kind of come back and watch this particular, at this point it's not there, but let's say in one day, I will be adding the link of the WhatsApp group in the description box. You can just come and join it over there or something. Okay, it takes around one day for the YouTube to kind of certify that particular link kind of thing. That's the thing. Okay, so you'll find it, like if at all you watch this particular video after a couple of days or something, you'll definitely find that particular link down. Okay, so that's all guys. So thank you so much. See you tomorrow. And yeah, bye. Good night. See you. Happy studying. See you tomorrow.